second delay.
Okay. It's 20 seconds for
Yeah.
the live stream. Oh, that's gotta be tougher questions. We will have just moved on to some other topic by the time they ask a question.
Yeah. To leave it a bit of time. Can you start seeing it?
Oh, that's gotta be tougher question.
Is the link working?
It's working, but it's funny to listen to the voice after a while.
Yeah.
Okay. Hmm.
Yeah.
Cool.
Yeah, at the beginning we should ask Zoom participant to like mute the YouTube channel, otherwise like it will like go back.
Yeah, sometimes it happens.
Yeah. Yeah, Liang. All right.
Yes. Everything okay?
No worries. Yeah. I don't know. Your background is like mirrored in the YouTube.
Background was mirrored in the YouTube. That is strange.
But it's also mirrored in Zoom, I think, no?
Yeah, you can change it.
Look as the right background. Yours is opposite.
Background was mirrored in the YouTube.
What happened to it?
No, yours is okay, Luke. I think.
Lucas, okay, yeah. You can change. You can change it.
Oh, I see.
Look as the right background. Yours is opposite.
Mine's okay now? Background was mirrored in the YouTube.
What happened to it?
No, yours is okay, Luke. I think.
Lucas, okay.
Now it's okay.
I think I see it mirrored in Zoom, but it's okay
change,
on YouTube.
So now it's okay, right?
Yeah.
No, yours is okay, Luke. I think.
Lucas, okay.
Now it's okay.
I think I see it mirrored in Zoom, but it's okay on YouTube. So I think, okay, yeah, now it's okay, I think. My background is actually mirrored in the in Zoom. It's
now it's
strange.
okay.
Okay, I think I see it mirrored. It's so confusing to hear like both YouTube and Zoom. And then there's actually speaking. So I think someone in the past, or
yeah, make sure to like mute YouTube.
So we are also recording this with Zoom Cloud, so we are able to edit it afterwards.
Hello.
Hi, Florence.
Simon, you're very blue.
This is bullshit. Look, I found green, but it doesn't work.
It's almost there.
Yeah, almost. Okay, it's gonna be white.
So you
got
gotta
it.
go on paint, cut out like a shape, and then just stay still
Yeah.
with the shape. You're fine.
Morning, guys.
Morning, Florence.
Hello.
Hi. Yeah, it's gonna put on a white jacket, but the background has white in it too. Let me go change. Better.
Good.
Hi, Professor Jitangi. I think you are muted.
We have some more time, right? I just joined in a bit early.
Yeah, yeah, we have around like another 20 minutes. Yeah.
Okay, yeah.
Yeah.
So nice to meet all of you.
Yeah.
Nice to meet you.
Hi, good morning. Hi, nice to meet you.
Hi.
Realize
Hello.
it's morning just here.
Nice to meet you.
Now you are in Australia, right?
I'm in Brunei.
Oh,
Okay.
cool.
Okay.
So it's evening for me.
Yeah. Okay.
Okay,
Right.
yeah.
Yeah. Sure.
Okay, so maybe I'll pop back in about 10 minutes time.
Yeah. No worries.
Yeah, sure.
Okay.
Take your time.
Yeah.
See you later.
Okay.
So I think I also was confused with the time, maybe between UK and Europe. So maybe I come back in 20 minutes.
Hi, Angela. Yeah, nice to meet you.
And nice to meet you too, guys.
Hi. Yeah.
Is my background too much color?
Tokyo.
It's fine.
Tokyo.
Yeah.
Yeah.
Tokyo
so
Uni.
that-
Yeah.
No, maybe because I was looking to like Italian time, and then now it's already 10 maybe, and I got confused. So.
Central
Hi,
Hour.
Trish. Hey, Trish.
You're muted.
Yeah,
You are muted.
Hi, Trish. Morning.
morning. Good morning, Angela. Good morning. Ohio gozaimasu. Ohio.
But actually, here is evening, so
Yeah,
konbanwa.
Konbanwa. So is that University of Tokyo background, Angela?
Yeah, it is. Onko campus is the main building.
Yeah.
Right. Oh, how can I get this RoboPat background?
Trish,
Did
yeah,
you email it?
yeah.
I can drop
Liang sent yesterday.
Let me check.
I drop it in the chat. You can use it if you want.
Oh, you put it in the chat. Okay. Cool. Okay, then. Show background. Done. Right. Cool. So I think it is good to put the YouTube link on social media because people may not notice that.
Have you got it on Twitter?
Did you? Can you tweet? I can retweet.
Paste the link in the chat. You can
Yeah,
find
maybe perhaps Trish can do it.
Okay.
So
I will
Yeah.
do it.
Yeah.
the link is in the chat.
Should we do it now, saying it starts at 10 a.m. or we
Yeah.
do it at 10 a.m.?
Yeah.
But I already opened up the live stream link, so
Yeah, even they can join now. Yeah.
Oh, I see. Right. No, let's be careful. Let's do it at 10. Like, we don't want to people to kind of, get pissed off. Okay, what am I listening to? These people are talking crap. So just to make sure, I don't have to say anything, right? So I just sit in the background. You guys
You can
know
ask questions.
how to manage. Okay.
Yeah.
I mean, I can ask questions. That's not
Yeah,
oh, Jitangi has
absolutely.
joined. Good evening, Jitangi. Oh, good afternoon.
Yeah,
I think
she was there, and then she left and said, "Come back by 20 minutes."
okay. Just to make sure, I don't have to say anything, right? Oh, right. So now you had to mute something.
Yeah, mute the YouTube site.
YouTube.
Yeah.
Florence, at the
Yep.
beginning, you should tell that to all the Zoom participants to mute.
Oh, okay. Yep.
No,
Otherwise, like,
I don't think they are playing YouTube.
Actually, they won't be able to see YouTube because we only send them the Zoom link.
yeah, but it's in the website. We have already showed the link. If they want, they can.
Website.
I just in the morning I just watched Rachel's video. It is really nice, that facial expression thing.
It's in the
Yeah.
Yeah, they take a data-driven approach, so they just
Yeah.
randomly generate various expressions,
and then ask people to.
then ask people to categorize them. I
Yeah,
mean,
yeah.
that's a kind of a yeah. I mean, you can do it in a pseudo-random manner, like hand
Yes, yes.
manner, but not. But it seems to be working.
Guys,
Yeah,
I
that's
will share my screen first. In that case, I have a screen on the YouTube channel that will remind a reminder for the panel discussion for the moment before we start.
yeah.
Yeah, sure. Mhm.
Cool.
Yeah. Liang, is it still streaming or we stop it?
It is streaming now. Yeah.
Yeah, I think it's better to stream this.
Yeah.
And then when you clip, you can have a clip.
Yeah.
Hello. Hi.
Meet you.
Hi.
Thanks for joining us.
Thank you.
The Professor Chiu is from Australia?
HK.
Hello.
Chinese University of Hong Kong.
Chinese
Yes.
in Hong Kong. Yeah. So Dr. Angela Faragaso she is now in Tokyo.
Hello, everybody. Hi.
Hi.
Nice to meet you all.
Okay, we are on air now.
Right, thanks, Liang.
We're going to shut
Perla.
4 minutes.
So, Arvin, how's the situation in Melbourne?
We're slowly easing up the restrictions, just in time for the footy final. So unfortunately, we had the second wave, so things got quite bad back in July, and we went to quite a severe lockdown. Yeah.
And it's opening up now. I read that it's going to expand to like 25 kms.
25 kilometers, that's right, yeah.
All right.
I mean, I've been lucky because I've been able to go, well, not exactly interstate, but a few of the regional hospitals where we had access. So that was fine, but I was barred from going interstate, couldn't go to WA or New South Wales. Yeah.
Oh, well, glad to know that it's getting better now.
Yeah, weather's warming up as well. So yeah, looking forward to summer.
Yeah.
Yeah, nice.
Hi, Dr.
Hi,
Maslak.
Master.
Yeah.
Hello.
Hi,
Paul.
Dr.
Yeah, nice to see you here.
Hi, all. Just let me get myself sorted out here.
Okay.
No problem.
Hello.
Hi.
Hi.
Tom is from RMIT, Melbourne.
Yeah. Welcome. Florence, I think yeah, good to go. We have like 2 minutes.
Yeah, I think we have all the speakers in. Yeah, let's start at 10 sharp.
Yeah.
All right, just a gentle reminder. So we have Zoom and YouTube live stream on at the same time. So to make sure that there's no audio interference or anything, please make sure that for all of us who are tuning into Zoom to mute YouTube audio. All right, thank you. Okay. All right. So we're at 10 now. Oh, Simon's coming in. Hi, Simon. Good morning. All right. So I think we can start since it's at 10 o'clock now. Okay.
Yeah.
Right. Hi, everyone. Welcome to the RoPat Ideation panel discussion for our workshop on robot-assisted training for primary care, with the big question on how robots can help doctors in medical examinations training. I'm Florence, one of the workshop organizers, and we have Trish. Hi, Trish.
Yeah.
Hi, Tilina.
Hi.
Hi. Okay, we have Liang. Hi, Liang.
Hi, Florence.
Fumia. Hi, Fumia. Morning.
Hello.
Right, and we have Luca.
Hi, everyone.
Hi. And Simon. Simon.
Hello.
Perla.
Hello, everyone. Good morning.
Yeah, and also we have Josie. So unfortunately, Josie won't be able to join us today. Yeah, but she's part of the organizing team too. So yeah, as we all know, this year has been really strange and interesting with all the COVID thing and also the restrictions across all nations. Otherwise, we would most likely be flying off to Las Vegas today. Yeah. Well, despite not being able to attend the workshop physically, we are so delighted that we are all gathered here today live on our meeting. Our exciting discussions. So we have panel speakers from all over the world in both the clinical and technical fields. Thank you all for joining us today, and it is such an honor having you with us. So we also have workshop participants tuning into our discussions on YouTube live stream at the moment. So our participants are most welcome to interact with us by dropping questions or comments in the YouTube comment box, and we'll pick it up to actually address during this discussion. All right, so I am the chair for our first panel session today. Without further ado, let us begin with a brief introduction and sharing by our panel speakers. So in panel one, we have on the clinical side, Dr. Dan Tiruchelvam from Newcastle and Professor Philip Chiu from Chinese University of Hong Kong. And on the technical side, we have Professor Kazuo Kiguchi from Kyushu and Dr. Maslakajari from Imperial. So I'll first pass the mic on to Dr. Dan Tiruchelvam. Yeah, would you like to share with us?
New South Wales, but I was in Melbourne for quite a long time, and that's where Florence and I interacted on some research. I've got quite an interest essentially in robotics and how that can help medical training, in particular in relation to surgery. So there's been use of robots in surgery for quite a while, but its extension to even training medical students for junior surgical trainees or registrars is very important for a number of reasons. One, there's a decrease in overall clinical exposure to patients. Two, society demands that, gone are the days, even though I'm a young surgeon, I think that society now feels, look, rather than somebody in inverted commas practicing on patients. They really need to be training and learning those skills on some sort of simulation or robotic model. So I've got that interest, and in fact, Florence and I worked on some magnetic actuation models in robotics in Melbourne. So I think really the future of surgery is no more just the human surgeon and the patient. There's got to be a robotic interaction in between that for precision and training.
All right, thank you, Dr. Dan. All right, so let's hear from Professor Philip Chu.
Hello, everyone. Really nice to meet you here. I'm also an upper GI surgeon working from the Chinese University of Hong Kong. Florence, may I share? I have prepared a short PowerPoint slide. May I share?
Yes, please.
Yeah, okay. Okay. Can you see my slides?
Yes, you can.
Okay, so I'm going to talk a little bit about education and training in robotic surgery. And so this is when we introduced minimally invasive surgery in Hong Kong in the 1990s, the first laparoscopic cholecystectomy. And I think that is the time where surgeons actually taking out of their comfort zone and from the open to the minimal invasive era. And that's where also we are just treating disease with a small incision. So the challenge will be, yes.
Sorry for interrupting. Yeah, I think there is a prompt box on. Yeah.
Okay, so
yeah, thanks.
Is it okay?
Oh yes, it is okay now. Thank you.
Okay, okay. So I think the training also changed over the past 20, 30 years. From the knowledge we learned from the seminar room all the way to virtual reality room training. And then we go through the surgical skill lab before any kind of operation being performed. And then we go on to the operating theater, and the surgeon will first be serving as assistant before they would be the chief surgeon who will be performing the surgery under a proctorship. So, and I think what we are having now is in fact a upgraded system and also the tool that allow us to have a more precise and high quality of operation using the robot, the Da Vinci robot that we now have. So this is one of my procedure of performing a lymph node dissection over the right recurrent nodular nerve, which require a good quality and delicate movement. So the robot actually provides with a very stable platform to achieve that purpose and a high quality of a surgical dissection, especially for quality lymph node dissection for cancer surgery. And so how can we bring this forward to train surgeons to use different kind of tool in the future? I think now with the different model of training, you have the simulation training for robotic surgery, and there are multiple systems that allow you to do so. While our center actually established the first robotic surgical training center outside US and Europe back 12 years ago. And we actually believe that we should not only focusing on the training of the tool, but also we need to bring the surgical procedure forward. So we are focusing on the animal model training and cadaveric model training, as well as to have a clinical hands-on training as well. So this is the number of training courses that we have organized over the past 12 years. And we are relying on simulation, animal model, cadaveric model, clinical case observation, and the proctorship. So there's always an argument whether simulation can help us to overcome the skill learning. We can learn some basic skill during the simulation training, but there are issues with simulation as well, because the surgeon will always think that this is not real, and they cannot overcome the variation in the clinical setting because of various kind of disease stage and also the anatomical and also the pathological variation. So animal model can help us to overcome and allow us to have a more real feeling of tissue handling. But we also face the problem of that this is not a real disease clinical situation. So we may actually be not able to simulate the real life dissection. And the animal model that we are using is mostly pig, and some of the organ cannot simulate the human. So the other option in the future that we may be considering, and of course for the panel discussion, is whether VR, AR, or even mixed AR, VR training should be adopted. And I think this will be greatly enhanced with the 5G technology, where we do not need to travel. Maybe we just have to be here in our room, and we can already situated over the training. That would bring the barrier for physical training. And the other is the model, whether you should be developing some robotic simulated model or 3D printed disease model that help us to overcome the changes in the disease and also the anatomical and pathological environment. And in the future, we probably also have some image guided robotic surgery. And this will also pose the challenge of the role of a surgeon for the next future, and how we should proctor and train a surgeon in the future. So thank you. This is my all my sharing. Thank you.
Thank you, Professor Chu. That's a very interesting pitch on surgical robotics training. So let's move on to our technical speakers. We have Professor Kazuo Kiguchi.
Hello, I'm Kazuo Kiguchi from Kyushu University, Japan. So I'm an engineer, and I mainly work on human-related robot. One of the main research topics is rehabilitation robot, especially real-time estimation of motion intention based on biological signals of the patient is my interest. And that is very challenging to realize effective human-robot interface. And I'm also work on human motion simulator, such as human joint motion simulator, to investigate the optimal artificial joint replacement surgery or ligament reconstruction surgery. And also developing a laparoscopic surgery simulator for the practice purpose is another my interest. And especially I'm interested in mechanical properties of virtual model to generate a realistic force feedback. And furthermore, task evaluation in the surgery simulator is also interesting for me. So I'm glad to participate in this partners discussion today. Thank you.
Hey, thank you. Yeah, thank you for your sharing, Professor Kiguchi. So last but not least, we have Dr. Maslakajari.
Hi. Well, thank you very much for the invitation. It's a pleasure to speak here. So maybe I will be a bit of a fraud to this panel. So my background is mechanical engineering, and currently my research is focused on biomechanics of injury. So then how it is related to using robotics in medical practice. So I came to learn a bit more about this area in my collaboration with Frisch on RoboPatient. Actually, I learned that most of the skills that we have in biomechanics of injury can be translated and can be quite effective in addressing some of the challenging issues. So I'm pleased to see that, for instance, simulation was mentioned here. So one of the key methods that we are using in biomechanics of injury are computational modeling. So all the time, our purpose, our aim is to increase the fidelity of our computational models. So in situations where the forces can be dangerous to human body, of course, we cannot use human body. And we know that there are lots of limitations with the physical surrogate models that we have. For instance, one of the surrogate models that we often use, and perhaps you have seen in car crashes, is the hybrid 3 dummy. It is quite sophisticated, it's quite expensive, but we know it has major limitations. And now in some of the consumer testing, like NCAP or Euro NCAP, computational models of the human body, whole human body, is going to be used to rate vehicles, to rate cars. And I believe the same expertise that we have here on tissue dynamics, on modeling tissue dynamics, making precise predictions of the effect of forces on the human body, on tissues, not in macro scale. We're also working on micro scale modeling of the effects of mechanical forces. So that can be translated into this area, and hopefully we can help to improve the robot-assisted medical training this way.
Great, thank you, Master, for the amazing introduction. Right, so now we are ready for our discussions. And well, speaking of COVID earlier, we know that many people has been impacted by the situations in many different ways. So during a clinical interview that I had with Dr. Dante Richelvam a couple of months ago, we touched briefly on this topic. So it will be pretty interesting for us to further our discussion here. And yeah, let's start with Dr. Richelvam. Would you like to share how the COVID situation and restrictions have affected your medical examination practice so far?
COVID has affected us in multiple ways. So one is obviously there was the stress associated initially with COVID coming on. That affected things on multiple levels. So in individual practice across New South Wales and Victoria or Australia, there was changes in clinical practice, changes in training. Some of the universities were saying to students that they couldn't attend clinical placements to try and minimise exposure. There's been changes in the types of surgery that were performed and the numbers. We're very lucky now. We're in New South Wales. We're actually back to complete normalcy. But the interesting, or I suppose it's not interesting, one of the sad parts to obviously what's gone on in COVID is that there's this huge wave of work that needed to continue. One interesting clinical scenario that came out of it was this shift towards telehealth medicine, so both consultation and otherwise, and it brought home some of the limitations of putting an interface between you and the patient. So that's important in both sort of robotics and clinical practice, but also discussion with patients. So I think patients and myself were very relieved to go back to normal clinical practice where you could see the patient and examine them. And so when we talk about robotics in surgery, that's an extension of the telehealth model, that there is a barrier, whether that be a virtual barrier or a physical barrier or a lack of haptic feedback or any of the number of things that we've looked at in robotics that changes how we practice. So it's been widespread, those changes during COVID, and I think we're only going to see more of that later as it progresses. So, yeah.
Okay, thank you, Dr. Dan. And yeah, for Professor Chiu, how has COVID affected education and training in the side of medical practice?
Yeah, I think we share the same situation that our medical student cannot come to the ward and they would require a online training, but we have seen the deficiency of having the online courses because they could not appreciate the kind of physical sign that we can directly in contact with the patient, and also it cannot replace the real life physical training. So that has a tremendous effect. And secondly is that we are also limiting in terms of the preclinical surgical training because we did not actually organize any kind of physical workshop that trained the surgeons in terms of the new surgical skill, simply because we have to have social distancing. And so that also the other thing that COVID affect us is that they drawn a lot of the clinical manpower to focus on management of COVID cases or prevention mechanism to spread of COVID within the hospital or in the community. So that draw a lot of our manpower, and that jeopardize the teaching, training, education as well. So I think these are important issues, and probably in the future we also need to think about the solution of if there is any kind of situation that would happen again. So that may jeopardize a few years' time of medical training. And also perhaps there are increasing establishment or the acceptance of kind of online management or actually the AI and the robot. So I think that this is a time that we have to think about in the future how we should adopt this technology to help situations like that.
Right, thank you, Professor Chu. All right, so technically, Professor Kiguchi, can you share with us some of the strategies that you know in implementing robotic tools to assist remote physical training and examinations like this?
Okay. For the medical training, development of a robot patient will help remote medical trainings. Since physical contact with a real patient or subject are not required. And also the tele-examination, such as tele-diagnosis, has been already studied using a master-slave robot. For example, an ultrasound probe can be controlled remotely by a medical doctor using that system. So they will help remote examination. And telesurgery is also possible using a master-slave robot, such as Da Vinci robot. So that kind of tele examination or tele-diagnosis will be important. And also, if we have a robot patient, that will be very helpful for both diagnosis and tele-examination, and also the training. And furthermore, the visualization of the patient physical condition using the certain sensors are very important. So if we can visualize the patient physical condition easily, then that will be very helpful for diagnosis and also the medical training also. So the robotic technologies will help to visualize the physical condition of the patient using those sensors. And robotics technologies will also help to evaluate the clinical skills. So for the training, evaluation of the skill is very important. So using the sensors of the robot, probably we can establish the way to evaluate the clinical skills. So that will be very important for the training, and that can be performed remotely. So that will be very helpful.
Right, great, thanks. Yeah, so all right, for Mustak, how do you think our current technologies, for instance, AR, VR, could help could help doctors in the remote platform for examination training?
Yeah, so that's a good question. So as you said, current technologies, so we can of course think about future as well. But currently, I believe we have good technologies in hand that can transfer some of the very useful information that usually doctors gain when they do face-to-face physical examination. For instance, we can have a view of the patient. We can hear the sound of the patient. Maybe one of the challenging bits is haptic sensing. And this is something that remotely is a bit of a challenge, how we can simulate it for the examiners remotely. So I think this third source of information is something that I believe the technology is moving towards it, but still we are not there. But I would say in terms of the auditory and visual information, we have the technology. There is already some apps out there. For instance, I know there is an app that is called the Good Sam. Actually, the inventor of the app was awarded an OBE recently. So this app enables normal people to make a call to the emergency center, and they just hold their phone on the face of the patient, and then the doctors just sitting at the center, they can see the heart rate, they can see this respiratory function, etc., and they can provide some advice before the emergency services arrive at the scene. So I would say that technology is already there, and probably we can start utilizing it. And as you mentioned, with AR or VR, we can give a bit of a better sense to the doctors when they're doing this examination remotely. But I think one challenge that we have, probably we'll discuss about is haptic sensing.
All right, thank you, Mastat. So let's open up for questions from the audience or from any panel speakers who would like to chip in and discuss. So you can also type the question in the chat box and I'll read it out.
So
Mazdak, sorry.
Just a question for Mazdak. So one of the issues in surgery is really around the haptic feedback, right? So the Da Vinci, which is the most well-known robot, and there have been a few others that have come and gone, and there was one that came recently. I can't remember the name of it anyway. But it really doesn't get to the sensation levels that we require. So already during laparoscopic or keyhole surgery, we have a reduction in haptic feedback, and we've learned to deal with that, and same with the robot. But what is the barrier to getting appropriate real-time haptic feedback from a robot?
Well, I would say that's a difficult question. So what I can think is perhaps the sensors themselves. So I am familiar with a few sensors that are being used to measure forces. So haptic feedback, of course, it's the effect of the contact between two surfaces, and that is the pressure that is being exchanged between these two surfaces. So I think in the first place, we need reliable sensors to be able to measure these forces. But then when it comes to human finger, I believe it's such an intricate and complex system. So we should really get to the bottom of how the finger is sensing different objects, and then how sensors can simulate it for us. So we can put sensors, but when we collect this data, how we can then transfer it into perception of the sense that human perceives. And I think that is one of the challenges that I believe in the robo patient, that is one of the issues we are looking at. So with computational modeling, actually, we can then look at a fine distribution of the forces on the finger and how it is interacting with different tissues, and when we have several layers, for instance, in the abdomen. And then we want to translate it into the perception and see how we can link these two together. But I would say the main barrier to me seems, first of all, the sensing technology, and second, how we link it to human perception.
Great, thank you, Mastat. So in terms of sensors and haptic feedback and all, so Professor Kiguchi, do you have anything to add?
Well, actually, in my opinion, force sensor must be installed on the tip of the tool. But in the case of surgery, it must be disposable sometimes, and or we need sterilization for the sensors, and that will be very difficult for sensors, basically. So we must study more about the force sensors for the surgery robot. I mean the practical force sensors. So the other method might be that another method to estimate the force, not directly from the force sensor. So for example, if we use machine learning, we might be able to use visual information to detect the amount of force. So that might be another possibility. So not only just sensor itself, but also we must think about that using that machine learning method. So that is another possibility.
Thank you, Professor Kikuchi.
Florence, leading on from Professor Kikuchi, I think that's important because when you talk about the hands, okay, we now really do a lot of stuff laparoscopically. So I do very rarely do an open operation. And if you're wearing 2 pairs of gloves, you're kind of muted. The difference in laparoscopic surgery is exactly what Professor Kikuchi said, is that there may be a lot of force on the instrument, but that force is related to torquing on the port rather than on the actual tissue. So the machine learning with the visualization is probably more of an indication of the force required to do the operation. So that's a very important point that I think Professor Kikuchi just brought up.
Thank you, Dr. Dan. So for Professor Chu, so when you're doing like training and education with medical trainees, how do you actually interact and communicate with them when they're actually doing it on hands? And at the moment, with this remote thing going, do you actually use a platform to teach them, or like through visual cues, or even just through verbal?
Yeah, I think at this moment, when we are teaching the medical student online, we are using, in general, just like any kind of communication platform. Zoom is one of the most common, and I think in terms of the communication, questioning and the understanding, it is fine to use that. But at the same time, we actually lost a lot of the human communication through maybe a kind of body language or the gaze that we have. So also the minor point that we may be missing, especially when we cannot teach them physically through a patient's education. So that is one of the missing link for a medical teaching. And I think it cannot be replaced by the current technology. And at the same time, I think for the surgeon, we are actually teaching them inside the operating theater. When we are still running our operation, it is fine. But the issue is also because of the COVID situation, we are limiting our manpower. So maybe some of the procedure, because when we are having a high instance of cases of COVID, we are limiting the number of surgeons that are participating in the surgical room in order to avoid and lower the risk of the infection transmission. So that would also jeopardize some of their training opportunity. And also sometimes when we are operating on the case, we prefer to have a more experienced person to complete the procedure in a faster and a high quality manner. So they are actually jeopardizing the training opportunity as well.
So prior to all these lockdown and remote measures, how was your training experience like with students? So when you're using like surgical tools, as mentioned by Dr. Dan and also Professor Kikuchi and Maslak, so haptic feedback is really important. But currently we don't really have like a platform that has a direct haptic feedback. So do you usually use like visual cues to actually,
I am a little bit contrary to think that haptic feedback is important. In fact, we have been, with the start of the minimal invasive surgery, we have been taken away all this haptic feedback. So with the use of the two instruments, we feel something is not a direct feeling. And then subsequently with the robot, we are operating without any feeling. We just rely on our visual observation of the dissection and to feel like we are feeling. So there are a lot of, kind of senses that we can replace. And I fully agree that perhaps the image will become more important because image analysis will be a kind of maybe better data. I don't know, but the engineer can tell us maybe another good kind of data analysis with the image processing so that we'll be simulating the kind of feedback that allow us to achieve a same dissection quality for the surgical procedure using the robot.
Great, thank you. Okay, so I can see that we have a question from our participant through YouTube live stream. So this is from Luke Holland. Thank you for your question. All right, so I'll read it up. Clearly, there is a barrier in terms of haptic sensing, but I would imagine that the larger barrier is through the actuation of the haptic simulation to the doctor. Has work that you know of been done to represent this information through different sensory modality? Like, for example, representing the haptic information as a sonification or visualization that doctor could learn to understand. Yeah, so I guess this point has been also like discussed during our discussions with our panel speakers. And instead of using just haptic, we also use like visual and yeah, to compensate for that feeling. Yeah, so any of our speakers would like to add to that?
I mean, I think I agree with what Philip was saying, and in relation to that question, that a lot of what we see during laparoscopic or robotic surgery is the visual cues. The difficulty is how you train somebody in that, because Philip probably of my generation, I think, looking at him, so he would have had some open surgery, some laparoscopic surgery, some robotic surgery. So we have had the benefit of touching the tissues and feeling and knowing the tension, and then moving to laparoscopic and robotic. When you're learning, this is the difficulty when you learn straight up on robotic and you get somebody, it's how do you teach them that that is too much force? And there are things that you can teach them on a screen, but I think allowing a robot, so the more modalities of information that you get, whether that's visual, or feeling, the better. So, you know, I think but the visual cues will still surpass all of those, I think, moving forward.
Great, thank you, Dr. Dan.
Yeah, I think I also agree and echo. Yeah, I same generation. I go through open laparoscopic and then robot, so we have the feeling of the tissue tension and how we would not be injuring by applying too much of the forces. But in the future, and not in the future, but now our young surgeon has already been trained, you know, just started with a laparoscopic and then going to a robot. So that feeling, that touch on the tissue handling is not as precise as we have, because we have the feeling of the tissue. So how do we actually, and the new generation probably rely a lot more on the technology. So as we see, many of them are actually holding their mobile phone all the way. So perhaps we need the technology that can be warning them that too much of the force, or that the procedure may not be best by performing in such a context. So maybe that would be requiring a AI or image, you know, analysis real time to give the surgeon a red alert, or to teach them or to monitor them how the procedure can be performed in a higher quality kind of surgical procedure as compared to the expert.
Actually, that was my question. So, of course, to the clinical experts, that which direction you would prefer the new surgeons to go. So, would you like them to practice more on the real thing and feel it and understand it, or would like the technology to progress like AI? Actually, I had that in mind, that maybe the robot can make decision for them. So, which direction you prefer?
Both, a mixture. So you have to think about it. You have to practice. You have to read it. You have to watch some visualization. You maybe practice it on some sort of simulator. But in the end, you are going to have to learn on a real patient. But I think putting all of those steps in, plus some AI, image overlay, exactly what Philip was talking about. Maybe you can have some guidance saying, listen, you're dissecting that cholecystectomy, but you're now getting too close to the bile duct, and you get, you know, like when you drive your car now and you go out of the lane and there's a warning, you know, sensors or whatever, similar kinds of things with image overlay. You know, I think so a combination of both. Yeah.
Okay, thank you. So as we are coming close to our second panel discussion, we'll wrap up with just one more question. So anyone has any questions so far for our panel speakers? All right, so yeah, thank you so much, panel one speakers and everyone. It has been a really interesting and exciting discussion so far. Well, so I will now pass the mic on to our second panel chair, Tilina. Thank you, guys. And on to you, Tilina.
Yeah, thanks, Florence. Hello, everyone. I'm Tilina Ratna from Imperial College London. I'll be chairing this panel number 2. Beginning, for those who are in the Zoom meeting, if you have any question or comment for the panel, please unmute yourself and ask any question. And those who are joining with us through our YouTube live streaming, please feel free to type a question on the live chat section so that I can read them for you. Okay, and for the panel 2, we have 4 experts from both the clinical and technical background. I would like to welcome Dr. Tom Williamson from RMIT Australia. And then we have Professor Jitangi Wanigisinghe from University of Colombo, Sri Lanka. And then we have Professor Chi Chong Kyu from NUS, Singapore. And finally, we have Professor Simon Dilsignan from University of Oxford, UK. I welcome you all. Before moving to the discussion, I would like to invite each of you to give a brief introduction about yourself, so our workshop participant can know about your background. Yeah, we can start from Dr. Tom.
Hi guys, yeah, my name's Tom Williamson. I'm an engineer and a roboticist. I currently work at RMIT University in Australia, in Melbourne. And my research and my work primarily focuses on automation in surgery and the development of robotic systems that can make decisions and perform specific tasks within surgery. And this has covered a range of different clinical applications, from ENT surgery and orthopedics and some abdominal surgery stuff as well. So a bit of a wide range of things. In terms of robotic patients, my interest kind of lies in a few different areas. I think that aside from the potential advantages that we've talked about with training and things like that, there's also the potential to get new ideas and to work closely with clinicians on virtual patients in situations that might be rare or difficult to access, to get new ideas to start developing new technologies for different clinical areas. Yeah, so that's pretty much me, basically looking at automation in surgery.
Yeah, thank you. Professor Jitangi.
Oh, hi everybody. So I'm Jitangi, I'm from Sri Lanka, and I am a child neurologist. So I think we have several surgeons in the panel. So as for my interest in this, I have not worked on robotics at all. I have minimal exposure to use of technology. I guess some of the work that we have been doing with Tilina and the team from University of Moratuwa probably was my only experience or exposure to use of technology. But I think I'm here to share with you about the scope of using robotics and technology in children, because that seems to be a large area which is unexplored. And listening to you all, it's just amazing lot of areas where technology can be used. So I hope I can contribute with my clinical expertise and talk to you through some of the areas where in children where robotics can be used. So I am a professor in pediatric neurology, and I mainly deal with children who have epilepsy, where I think technology has a big role to play. And I also see a lot of children with disabilities, and I think that there is enormous scope there as well.
Yeah, thank you. Professor Choi. Professor Choi, you can.
Okay, can I share my slides?
Yeah, sure.
Can I share my screen? Yes, yeah. Okay, give me a minute, yeah. Yeah, sorry.
Yeah, okay.
Yeah, okay, so maybe I go to, okay, a brief introduction to myself. I'm Jigong Chui, Chui Jigong. So I'm with the mechanical engineering in US. So we did quite a fair bit of things: medical device, robotic imaging, and simulations. So I also try to see how we can actually the technology that we develop for medical application can actually be applied to other area. So actually, I started doing medical simulation, in mid 1990s. So there was a project between Singapore and Johns Hopkins University. So we want to develop a simulator for interventional radiology. So it's very much like a flight simulator for pilot. It took a long time to train a qualified interventional radiologist. So the focus is actually on the provisions of realistic hand-eye coordinations. So there are a few things that we actually need to solve, a few technical issues that we need to solve. We need to have a good finite element. We need to have a good computational method to actually model the interaction between the catheter and the vessel wall, so that the trainee will actually learn the right thing. So I mean, also in the previous panel, we actually discussed a lot about the haptics. So the same thing for us, we experiment with haptics as well. But what happened here is actually with catheters. So catheter is actually going to a port. So somewhere like that, but you actually insert near, in this case, it's actually near the groin, and then you get the catheter up. So we actually kind of get a bit of a mix. Some say that the force feedback is very important. Some say that this does not. So we do a clinical, we experiment with the clinical students and obtain some clinical feedback. So actually at the end of the day, we are still not quite sure whether the force feedback is actually required. So the reality on the feedback, I mean, maybe the force feedback may be required or maybe not. The visual one, at that point in time, we still need improvement. But I think, so this is a fluoroscopic view, which is the X-ray view that the interventional radiologists will be actually looking at. But with now current technology, this is not quite an issue. So we do a lot of other stuff as well, like from the CT, MRI image, we construct the patient-specific vasculature system so that we can actually have a train of all the different types and so on. So, but anyway, this is not quite. This is very much like a flight simulator, a computer game. It does not actually teach. So about 10 years ago, we start working on having the robot being the trainer. So robot being the trainer, meaning that this is in collaboration with my clinicians, collaborating in NUH and A-Star Research Institute in Singapore. So we developed a robot. So what the robot did is actually will learn the motion from the master surgeon, and then after that transfer the skill to the trainee. I mean, essentially is to replace the hand over hand type of training for laparoscopic surgery, and then at the same time, of course, the trainee have the options of after training, the trainee have the options of actually operate the tools freely. Operate the proof release and then compare with what the expert surgeon is, and then from there we actually can come up with some sort of scores and so on. We do some tests. We do some clinical tests with the students, with the medical students. So currently what we did now is actually moving from the virtual to augmented reality. So this is our augmented reality systems. So one reason for that to move to the augmented reality system is that in an augmented platform, it actually provide some real object, and then so the real object itself. So what we have discovered for all the past years, the interaction, the computational method of modeling the interaction of the tools and tissue is very complicated. So by moving it to the augmented reality system itself, we may be able to introduce some real tissues into the systems for the training. And then currently the focus are actually very much on the robot learning the motions. So we have been using deep reinforcement learning of motions, and then so we also instead of focusing on hand-eye coordinations, we also look at the cognitive skill training, the tasks and so on. So with the augmented reality system and so on, we are looking at the surgical scene segmentation as well as the workflow recognitions. Yeah, so this is what we are currently doing right now.
Yeah,
thank you.
Thank you very much for the interesting presentation. Lastly, Professor Simon.
Sorry, let me unshare.
Yeah.
Sorry.
Hello, can I be heard okay?
Yeah,
Okay.
we can hear you.
Good.
Share, yes. Yeah, okay, yes, sorry. Okay.
Shall I go ahead?
Yeah, sure.
Please. Yep, I'm Simon de Lucio. I'm a professor of primary care and clinical robotics at University of Oxford, and a practicing GP family physician, and practiced in my current clinical setting, including being a training and teaching practice for over 3 decades, I'll own up to. And I very much enjoy work, particularly with health data. And amongst other things, I run the College of GPs Research and Surveillance System, which is the one of Europe's oldest surveillance systems, involved in flu surveillance for the last over 50 years, and more recently very active with COVID and facing some of the challenges other speakers have spoken to earlier in this session on the difficulty of teaching and training through the COVID crisis. My involvement with robotics has been through working with Thrish Nanayakara at Imperial, and I've really enjoyed working on the RoboPatient project. And the thing I've got most out of this is how it's opened my eyes to the limitation of our current approaches to training and teaching. And I'd almost want to echo, though obviously it's different in family practice where we're examining people rather than conducting surgery, but the lessons to me are really very similar to those talked about by our surgical colleagues earlier this morning. We used to have this idea that we watched one, we did one, and we taught one in terms of things with patients. And I suppose I've seen over the years when you've had a new student who looks very tense, and I think it's not only about finger feeling, but your arm tension and perhaps whole body tension, going to examine things, how clearly someone is not going to be able to feel the thing that they're setting out to feel or examine correctly because they've not had the any training or education in how to do this. And I think the real potential through this work with RoboPatient and other things to develop the things being taught of about haptic feedback and things so that people can calibrate the way that they're working and examining patients in a way that was never possible in the way that we traditionally train people. So I'm really very excited, like many other people on this call, about the sort of things we're doing and its potential implication for clinical training in particular, but perhaps also for those of us who are experienced clinicians to knowing whether what we're doing is likely to be achieving what we're setting out to do.
Yeah. Thank you, Professor Simon. Thanks all for your short introduction. Okay, without further ado, let's start the main discussion. So my first question is related to clinical practice, and hence this question is for Professor Jitangi. What are the type of information or sensation you look out for during medical examination? And the follow-up question, how do you train medical students to interpret this information?
Okay, so I think probably I might be echoing some of the things that we have been discussing already. I think let's take so I'll be more talking about, like, in my setup where, it's related to training in children in pediatrics, and as you would know, they are very difficult customers, and also in general, even medical students, even young doctors, like examining a small baby is difficult, And also there's so much of like, apprehension, and also, handling a baby. You have to be, have to have a real reason to examine, particularly when it comes to neonates. Like, it's not easy having access. And just like our surgeons described how there is limited access to operating theaters, like, setups like neonatal ICUs, where touching the baby is very limited, only to the caring doctor. So real exposure and experience for the students is actually limited in our practice in certain circumstances. So parents also don't really like, many people examining babies unless it's really a reason for the baby to be examined. So I think in medical education, in my field, I find that there is a lot of scope for simulation and for use, for training, students on, common things. Like, for example, everybody needs to know how to examine a neonate, but, really having access to do that very often. And it is a meticulous examination, which takes time and it requires practice. So if you could have a simulated situation, I think it really would help. And we can see how, their access to patients has been curtailed because of COVID. And also there are situations when we have very sick children, children who have conditions like immune deficiency, where it's just not possible to see them or expose them. So I think there is a big scope in that. And one aspect that we did not discuss at this point is, I think it could come in handy in our evaluations as well, because right now, okay, we have a system where we, score, we try to be objective, but it's all visual based. So I think in our assessment of students, as well as even young doctors or who are, budding to be physicians, pediatricians, we could have the situation where the patients, maybe not poor cooperation, things like that may not really hamper their evaluation process, and the evaluation can also be made more objective, I think. So that's with regard to medical education. Some of the examples that I can quote from my field, but I think I have different aspects that I can bring out with regard to the role of technology and robotics in medical practice. So first of all, I would like to take the same situation that not only students, but we face with the difficulty in examination. So in children, there are many aspects which are very difficult to examine. For example, you can never, we check the, one of the fundamentals is we check for the pupillary reflex. You cannot do it in a child, because the moment, they would, in the younger age, you shine the light, they close their eyes. So it would be, it's a valuable clinical assessment. So if the technology can do it for us, it would be, very useful. And in children, in neurology, we check to see how well you feel pain, how well you feel, how much you can see. Well, in the younger age group, when the findings are, they cannot express, plus their findings are not reliable, and they are very poorly cooperating to your examination, I see enormous scope with use of technology. So for me as a neurologist, I find it so difficult really to judge whether my patient, my client can see, very well. See means like, how well he can see. Can he see all the entire visual field, or is he just seeing one half of it? So it's very subjective assessment. So I feel that, I wish that technology would make my function easier, so that, I have a more reliable assessment of aspects which I cannot do in the real, situation. So, some other aspects with regard to, okay, examination, and then comes your assessment, your scorings, your scalings to, to judge, maybe the severity of a condition, and, how far we need intervention. So I find most of our judgments are, they are based on certain aspects, but they can be made more objective. So I think if I give you an example, it may be easier to understand. For example, in children who have what we call cerebral palsy. That's those who have early brain damage and they have limitation of movement. So we check for certain things as to how good their movements are, how active they are, and how much of disability they have, like how stiff their body is. So most of those assessments are actually based on subjective assessments. So it's how much I feel, how much do I think that the child is having stiffness in the body. But if I can use technology, or if I could use a sensor which would not be affected by the child crying or the child, not being very cooperative, I think it would make my, evaluation probably more objective. So, for example, use of EMGs and use of sensors, use of, different technology which could use to assess the degree of resistance in a more objective manner, I think would make our clinical assessments probably more reliable. And also it has the advantage of, being used repeatedly. So in our assessments, repeated examinations again become a problem because, I think if I may quote what from the first panel, Professor, I think Higuchi was talking about use of images. So you could store the images and then you could, here it's like, I could use a video and compare, but it's just my subjective assessment of the video versus, the current situation, or often there's no video. We actually think of what it was yesterday and we try to, reassess today. And then it's a visual assessment of how much of, say the gait has improved in a child. So if you could have a sensor which could do it, and also the sensor would be using the same parameters, and also the sensor could compare the image that was there yesterday and would be able to give probably a better and a more objective evaluation of how much the patient has improved. So I think, these are things, and in children, it's so difficult to perform. So therefore, I think there is a lot of scope in doing this as well. So the third thing would be therapeutics. I think obviously there's scope for therapeutics. We heard from the surgeons how robotics is used, but I am sure, like if I talk about the two main areas that I deal with, like rehabilitation, in an older person who has a stroke, it's very difficult to instruct the person and, explain, this is what you're supposed to do. This is, this is what you mean by active movement. But in a child, it's so difficult to do it. So maybe having like a robotic arm or a robotic game, or, and all interventions have to be like based on the age of the child. You cannot do the same thing that you do in a 6-year-old in an infant. So their, repertoire of activities, repertoire of play, they're so different. And then they are in a dynamic process where it is evolving. So I feel, use of robotics and particular skills that they know, utilizing those and then having processes which activate particular areas and, getting the, robotics to do some of the difficult tasks would really be useful. And I think, again, going back to what one of the first panelists discussed about, remote therapeutics. Like, for example, now when I am using Botox, I would need the radiologist. I need I also need the help of the neurophysiologist. So they all have to come to the theater, and then there is so much of overcrowding. And then so if we could do all these things remotely, I think the therapeutics can really be improved as well. So finally would be re-evaluations. I think I've already alluded to the fact that re-evaluations are, I think, ours can be improved and become more objective than what we do now. Repeating tasks is difficult. So I think there is scope for re-evaluations as well.
Yeah, thanks a lot. That's a really interesting answer. So in line with that answer, my next question is directed to Dr. Tom. This is my question. So what is the role of medical robots can play during medical examination? And then how robots can assist doctors in medical examinations?
Yeah, I think a lot of what has already been talked about comes up here. I mean, robots have a number of potential advantages over even the best kind of doctors and physicians, in that they can be very consistent and very accurate. So they are able to perform an examination in exactly the same way every time, and to perform it exactly as required, essentially every time, assuming, of course, you program the robot correctly and all of that kind of stuff. Beyond that, there is also potentially a lot of different sensor information that can be collected by robotic systems, possibly beyond what is currently or traditionally collected by doctors, that may be able to give some additional insight into the patient condition. And then, of course, there is also the potential to use robots for remote diagnosis and remote performance of procedures, where, I mean, I think that the COVID situation, as we've seen, developing systems like this has potentially become a bit of a priority, where it's possible to evaluate people with infectious diseases or who are otherwise unable to be examined for whatever reason, using robotics. And I think, yeah, so I think that those things are really, there's the potential for using robotics for diagnosis that is quite large, and I think those fields are kind of the obvious ones to focus on.
Yeah, thanks. That's very interesting. Yeah, so since we already discussed a lot about robotics in medical examination, I want to ask this question specifically for Professor Chiu on virtual reality. What are the challenges for developing virtual reality or augmented reality platforms for medical training purposes?
Okay, I think the previous panel, I think somebody mentioned about the virtual realism, all those things. The virtual realism, the computer graphic have progressed, have advanced very significantly over the last 20 years. You have very high-speed graphic cards and so on. So the virtual realism itself, I think is there. So you can create things that visually very clear, very realistic. But the problem here is, but there's still a problem. I mean, in my field, for example, for what I'm currently doing, I'm basically doing making a robot trainer. So robot trainer is, the robot is actually meant to train a human. I think the problem here is the intelligent part. So the intelligent part, in the accuracy of the physics. So for example, the tissue deformations, when you actually cut the tissues, and then how realistically it should be. I think the bigger problem here will actually be the blood flow. So for example, if you cut the tissue and then the blood start flowing out, and then the tissue deformation within the organ, and then the boundary condition is very well defined. So I don't quite think that the computational model is actually there yet, and I'm not very sure how far we can go from there. So the first thing that I think that's limited in this virtual simulation itself will be this computational model, or maybe to be more precise, will be a realistic biomechanical modeling. So and then the therapy itself is actually more than just deformation. Also, you may actually burn the tissue, and then once you burn the tissue behavior, the tissue property is actually changes. So when you actually cut, it actually behave differently also. And then because of our focus in actually doing in making a robot trainer, beside the realism itself, we actually want to provide add-on, value added to the visual scene. So it's not just the realistic itself, the realism itself. We also want to provide something called visual cue. So, like for example, if you are about to do something wrong, so you are supposed, or you actually exert too much of force and all those things. How we actually can best feedback to it. So of course, Haptic have been around for many years. I mean, we talk about the haptics and all those stuff. So, but actually when you, I mean, but it's actually for all this minimally surgery, laparoscopic surgery is actually go through a port. So a lot of time, this sensing can actually be mute. And then we actually perceive visual a lot more than the haptics. So, so in this case, we are actually looking at visual cue. And then, so how to actually best present this visual cue to the trainee. And then, I mean, we also experiment on audio cue, but but I think we essentially learn very much from what we see. So yeah. So I guess these are things that I think a virtual simulation will actually be lack of. Augmented reality will actually have probably will be another level of training, or could be another level of challenge.
Yeah.
Thank you.
Yeah, thank you very much. This was very informative. So based on the points that we discussed so far, my next question will be pointed to Professor Simon. So as a clinician, if you are given a chance to select a training platform for primary medical care, either using fully virtual system, like what you mentioned, or active physical mannequin like a robotic patient, what would you select and why? And then what features you would expect from such a system?
Okay. Well, I also need to know how much I can argue with the chair. Am I allowed a bit of both, or do I have to come down as one or the other? I mean, ideally, there are some things where you can see advantages for each. But if I was allowed one, I would go for the robotic patient. And I'll say why. I've a limited experience with virtual reality. But for example, where locally a new hospital opened, and the plans, they created a virtual reality ward and orientation thing. So, and you can imagine for students going to different firms all the time, that virtual reality of where you're going on your placement or how the operating theatre is laid out would be really useful. I've been on a fascinating virtual reality journey at an exhibition I went to where you were a sort of blood cell and you really got a sense of how the circulation might work. But our course clinical skill is around interacting directly with patients. Obviously, communication with them comes top of the list, but a very close second comes the need to be able to examine people and to differentiate whether this is a case that needs urgent attention or not. And I'm probably going to focus in talking about this on clinical assessment, and particularly examining the abdomen, because that's where we're working on the robo patient. And also I think it helps focus mind on what we're talking about. And I guess the first thing I'd sort of almost pose to everybody, particularly those of us who are experienced clinicians, is when did we actually learn in our careers? When I was a medical student, you didn't have an oroscope and a telescope looking in the ear that you held in your hand. You had a funny mirror with a hole in the middle that you had to focus a light down the ear hole. And to be honest, I didn't really ever see anything. But you had to sort of nod and smile to your teachers, or you'd be sort of humiliated in the group and get tense and get even worse. Similarly, it was alluded to by my pediatric colleague. When did I really start being able to focus on the retina and make a judgment about it? And with the abdomen, I find this, I've got, this is quite a hard question to answer, but I think after my training, after qualification, qualifying as a GP, it was only after a couple of years practice that I felt really confident. And so I think the learning process is a lot longer than perhaps we own up to. And also we've got no objective measure of when that skill plateaus, or if we're all throughout life on a learning curve, or people like me are in the decline phase. I don't know, I hope not. And so if we thought about the abdomen and something really very basic, is do we know that clinicians already time their examination with when the patient is breathing? Do we know that people have enough pressure that they can feel things, but not too much pressure, so that they cause too much pain. And I think there's nothing, you know, I've never, other than getting involved with Thrish and the RoboPatient, I've never had any feedback about whether this hand regularly causes my patient's pain. I don't think it does, or whether I'm using it adequately to actually feel the things that I feel I'm differentiating about. And they can be quite important. In yesterday's surgery, I saw someone I was pretty convinced did not have any sort of torsion of their testicle, and we are making these clinical judgments. And I think there is a real opportunity to, you know, things are not perfect yet. We haven't cracked this complete. There's a lot to do. But I think there's a real opportunity to both help students calibrate what they're doing, but also experienced clinicians, but also for us to teachers and leaders in medical education to actually know whether the curve towards optimizing what you do really happens as a student, or does it happen as a junior doctor as you get more experience, or does it actually take a couple of years in a senior role before you're really doing things right? And to me, no objective measures of these, and there are real opportunities to start acquiring them.
Yeah, thank you very much. Yeah, okay, now it's time for everyone in the Zoom meeting or our participant in the YouTube channel to ask any questions. Yeah, if anyone have a question for this panel.
I might just ask one for the clinical, my clinical partners on the panel here. You've spoken a little bit about, especially Simon, you speak a little bit about advances in technology that have happened as you've been practicing. How do you find that that you adapt to those changes in technology as you've been going throughout your career? I imagine that you've seen some pretty significant shifts. Are they easy to adapt to, or is it sometimes an issue? I'm interested in your thoughts on especially as robotics and things like that become more common, the adaptation of clinicians to those changes.
If I may, Chad, I think with a very small c, what makes family practice and medicine safe is we're all very conservative in a conservative, not a political sense. I think in the things I've done generally in informatics, I think only lawyers are slower than doctors. Maybe nurses are just behind doctors in readily adopting technology. And we've seen, for example, COVID has been great for me on my technological side. We don't issue any more paper prescriptions. We're doing all, you know, and these things enable things. And we need some sort of trusting small steps. I mean, I wish, for example, I had in my waiting room, which we only allow the immediate person waiting for the next consulting room, a sort of robot that could clean the chairs, very basic. You know, because if we had those things happening rather than a human doing it, it would start engendering that trust and confidence that's needed. So I think there's a lot written about the barriers to implementation and adoption of these things, and we really have to work hard at that. There also seems a hump about it that in the middle of the careers, when people are busiest, it often feels it's hardest for it to happen, whereas you can go for the younger people, and the people towards the end of their careers maybe have a little bit more time or a little bit more reflective about what they do. But yeah, that implementation really needs incentivizing and lots of work to get it to happen.
Yeah, thank you. We have another question, but unfortunately, time's up. So perhaps we'll try to answer that question at the end of this session. Thank you very much, Dr. Tom, and then Professor Choi, and Professor Simon, and Professor Ditangi for having with us and share your valuable thoughts. And then I'll hand over this session to Luca. Thank you.
Thank you, Selina. Hi, everyone. I am Luca Shimeka, and I work in the Bioinspired Robotics Lab at Cambridge University, and I will be the second chair for this third panel. And I'd like to invite all the speakers first. So I'd like to invite Dr. Randy Koh from the National Heart Institute of Malaysia. I'd like to invite Dr. Arvind Valdivelu from Melbourne University, Australia. I'd like to invite Professor Shinichi Irai from Ritsumeikan University of Japan. And last but not least, I'd like to invite Dr. Nana Singh from the Indian Institute of Technology, Delhi. Without further ado, then, I'd like for each speaker perhaps to give us a brief introduction of who they are and what they do. And so perhaps Dr. Koh could start. I think you're muted at the moment.
All right. Can everyone hear me?
Yes.
All right. Good evening or good morning to everyone. My name is Koh Hui Beng. I'm a cardiology fellow currently in the National Heart Institute in Malaysia. So thank you for inviting me to share my perspectives on how technology or maybe perhaps robotics can be applied in at least my field. Well, I'm not really an expert in robotics, but probably maybe I can share in the field of technology, in the field of cardiology is a vast technology in the field of cardiology. For example, in the intervention side, in the diagnostic side, you know, for example, when we want to assess the coronary arteries, to assess for any, you know, plaque burdens, we can do a CT scan, and then the CT scan is able to give us a quantification of how much the plaque burden is in the vessels around the heart. And that will also help us in guiding us on what to do during the angiogram procedure. And other things like, for example, a nuclear scan or technetium scan, where we do a functional assessment and where we can decide whether or not we need, how aggressive we need to go ahead in terms of treating the coronary artery disease, whether is there any benefit of, for example, stenting that particular area when we know that there is no ischemia, when there is no perfusion defect to the myocardium. And of course, there are other things in terms of diagnostics. For example, loop recorders, for example, it's like something like a small device where you implant it underneath the skin, where sometimes we don't know, some patients will have unexplained falls or syncopal episodes when you do an ECG, you don't see any abnormal rhythm. So sometimes what we can do is implant a small device, we call it a loop recorder, and then the loop recorder is able to pick up any abnormal readings, and that any abnormal rhythms can be transmitted and then can be alerted to the clinicians that something is happened, and then we can able to call the patient back early for review and whether you need to implant any device, for example, an ICD or so on and so forth. Of course, other things, there are all other things like monitoring purposes in the coronary care unit, the cardiac monitors, which will have a continuous ECG reading, for example, where it will alert us when there's any abnormal rhythm. So all these technologies definitely helps us in managing the patients in the critical care unit, and also during the angiogram procedure as well. Certain imaging procedures like intravascular ultrasound, where they will help us to guide us to assess the lumen size and what is the size of stents that we need to use, what our strategy is. That will help us to get an optimum results during the percutaneous coronary intervention. So yeah, there's a lot of technologies which should definitely assist us in the field of cardiology. And I think there's a lot of technologies out there which are waiting to come. And I think I've also come across as well robotics when they're doing the coronary angiogram and angioplasty using robotics, and where the clinicians, after they engage the catheter, and then they just step aside, go into the console, and then they just maneuver the wires and all. But I do not have the experience. I've only heard and read some of the articles, but never really had the opportunity to have first-hand such technologies, which I think can be good in the sense that because when you do coronary angiogram, there's a lot of radiation involved as well. So if you can minimize radiation to the clinicians, of course that will be beneficial as well. So yeah, I think that's a whole it's a promising future in the field of cardiology. So I think we are always open to new technologies and ideas which can benefit us as a clinician, and at the end of the day benefit the patients. Yeah.
Great, thank you, Dr. Kao. I'd like to invite next Dr. Van Velo to probably give us a bit of a talk of what you do and your expertise.
Thanks, Luca. Just briefly about my background, because I've had a fairly different clinical pathway compared to most clinicians. I was formerly training in neurosurgery before opting out and moving on to ENT. I had the privilege to work with the pioneer of robotic head and neck surgery in Australia, Professor Suren Krishnan at the Royal Adelaide Hospital. And it was from there that I then decided to pursue research in robotics, but not the clinical side, but actually the engineering and computer science aspect of it. So I ended up in London, actually at Imperial College, at the Hamlin Center for Robotic Surgery with Professor Lord R. Darcy, as well as Professor Guangzhong Yang. And I got to know some familiarity with some of the technologies which I applied in robotics and image-guided intervention. After that, I returned to Australia, and I'm currently with the ear, nose, and throat department at the INEA Hospital. And I'm actually probably the only clinician that I know in Australia where I'm pursuing a PhD in engineering in surgical robotics. So I'm working with the bionic ear right now, and looking at some fairly advanced sensors for the cochlear implant. That's the bionic ear. And if you don't mind, Luca, if I just can share a video with you. So I actually presented this at the Engineering and Medicine Conference at Berlin last year. So these are fairly advanced sensors. They are optical fibers sensors, which are actually embedded within the cochlear implant. So what you can see is actually an electrode of the cochlear implant, and you've got fiber optic sensors embedded within. And the whole idea is the surgeons, when they insert the cochlear implant, they can't actually perceive the force when it actually touches the sides of the wall of the cochlea, or whether it's going into a different chamber. And studies have been done where the perceived force is about 24 millinewtons by surgeons. But in reality, the injuries which occurs at the time of the insertion is less than 10 millinewtons. So these sensors that I'm working on actually detects force readings at 4 to 5 millinewtons and so on. So there's more to this research. It's a subject of a patent application, so I can't say more to it. Yeah, that's my current work right now. So I'm just going to move on to my pitch as well as to what is my vision for robotics. So I think the ongoing pandemic has essentially exposed the extreme shortcomings of public health. Furthermore, the indecision of the existing healthcare systems have been exposed, and this is quite obvious to everyone and clearly seen in both developed and developing nations with severe consequences to people's health and the global economy. So what I believe is required is an accelerated adoption of medical robotics within various levels of healthcare, from primary care to tertiary care. Robotics is one of the technology enablers in view of the availability of big data, providing the existing platform is linked within a health informatics system. this in turn should be fully integrated in the digital economy, which is what everyone is saying is the fourth industrial revolution. However, having said this will result in a digital divide with respect to clinicians. That includes myself, but simultaneously, it's inclusive to the consumers, that is the patient, as it will be patient-centric. So this can be achieved by focusing on customer experience, data-driven services, as well as predictive clinical performance based on analytics. The health security state that the world is going through provides an immense opportunity to rapidly prototype, test, and iterate patient-centered designs. So the end goal should be a prescriptive analytics model that is akin to a personalized medicine, where artificial intelligence provides a cost-effective and immediate real-world impact.
Yep, thank you, Dr. Van Miller. That was a good answer. Next, I would like to introduce Professor Hirai. What was yours?
Thank you. So I will share. That's right. Okay, can you see the slide? Okay, so my name is Shinji Hirai, so they're from University. So I myself is the applied mathematician, so in mechanical engineering. So now I'm studying the software robotics area. Okay, so here I'm just introduce two topics in this area. Okay, so what is called surgical simulation? In flat foot surgery. Okay, we have now the use of the finite element simulation. Of course this is the traditional technology, the existing technology. But this is a collaboration with the surgeons. Of course they are not familiar with such technology. So we are now tailoring this technology that can be applied to the flat foot surgery simulation. Okay, now we are doing several operations, simulating, and also we show how the surgical parameters. In this case, the cutting angle and cutting length, so on. How such parameters would affect the result. Then the surgeons can decide which is better. They can choose the appropriate operation. And also this another one, the second one. This is the oral care simulator. In this case, a physical simulator. The nurses they have to learn the oral care skills in medical school. But up to now, they are using such kind of how to say mannequins. But of course there are no force sensing capability. So that's why it is quite difficult to teach the force sensation to be applied. That's why we are now making physical simulators. In collaboration with the dentist and also the professors in nursing department. First we have developed left one, this one. Here we have put many sensors for each tooth. But it's somewhat quite complicated, and it is not scalable. We have decided to change something. Here we have only one 6-port sensor, but just attach the existing this simulator, we can detect the contact point. Here we touch something, we can estimate the force and also the contact point based on the geometric data of the tooth. Okay, so this is what we are doing now. Thank you.
Thank you, Professor Hirai. And finally, the last speaker is Dr. Singh. If you'd like to introduce yourself.
I think she's.
So I think, yes. So unfortunately, because of different time zones and so on, Dr. Singh couldn't join us today. So we can actually just start early in the discussion. I actually have a lot of questions in limited time since we ran a little over before. But I'll start with Dr. Ko. So I'm actually glad that you said that your background isn't necessarily robotics or you don't have that much experience with it, because I actually wanted to know from the perspective of a medical doctor, which doesn't necessarily have an insight in the technology of robotics, what kind of technologies you'd think would be most useful to you for what you do every day. So what kind of technologies do you expect in the future, say 10 to 20 years, and what can roboticists or engineers give you that really would help you in what you do?
Right. So the bread and butter that most of us do, or at least in training, is to do angiograms. That's the you need to be a safe doctor to do a angiogram, looking at the coronaries of the heart. There are models, plastic models, where you can practice doing this, specific ballooning techniques, putting the stents to open up the clogged arteries. But those are models, static models. In the everyday that we do, we are dealing with human beings, a moving heart, a constantly moving heart, where when you put in a catheter, the catheter is moving. So you need to train your eyes on the monitor, on a moving heart with the wire there. You need to estimate where is the balloon going to be. So as a trainee, when I first joined, I was very scared. Obviously, you don't want to mess up the heart. You can cause perforation, you can cause bleeding, can happen. And of course, you have your seniors by your side, you have your mentors at your side, you have your consultants at your side, by your side. But by the end of the day, you need to build up that confidence. So I think it's good that they be on your side, but I think if we can have some form of technology which can mimic the movement of the heart, the heartbeat, while you're doing those kind of procedures, then that somewhat gives us a real-time feeling, if you like, that we can perform the procedures and learn at the same time. And we don't want to experimenting or practice it on a real-life patient too quickly. Of course, eventually everybody has to start somewhere. As a patient, I think they probably wouldn't know that you are a fresh trainee meddling your heart, but it'll be nice to be reassured that someone who is meddling your heart is someone who's experienced enough doing all these high-risk procedures. And then, of course, there are other things that life and death matters, emergency procedures. For example, when you have when you have fluid around your heart is moving, you have fluid around the heart, you have to insert your needle to try to decongest the fluid around the heart. The heart is moving. So as you put your needle to decompress, there's always that risk of the needle puncturing through the heart. All right. So those are emergency procedures which we have to do. Of course, we do it under the fluoroscopy guidance and all. So again, if there is such a technology which we can practice on doing such thing, and if we really do something wrong, and we, like, for example, we actually punctured the so-called robotic heart, and then as we know, okay, you failed, so you have to try again. So of course, all these kind of thing, which not to my knowledge, I've not seen one done, but it's all these procedures, high-risk procedures, is always we are learning as we go along. So I'm thinking, like, why are we learning as we go along if we can start somewhere? Build our basics, build our foundations proper, and then of course, and as you learn and you go along, you get the confidence, you can perform in a more confidence, and also in a calm manner, because it's not something new for you. Yeah, that's my take.
Yep. Yep, great answer. Thank you. This is actually very to the point. I actually wanted to ask Professor Hirai from your background in soft robotics and what kind of actually technologies you think are at the bottleneck right now. So is it a matter of material science? Is it a matter of, I think we talked about simulation and we talked about haptics as well, right? So what's missing? What steps should we take next?
Okay, maybe so the, yeah, okay, so the, maybe so the, one candidate would be kind of active materials. So the, now so the, we have some material scientists now working on so the materials. Okay, so the, that's where also, for example, so kind of sort of vibrate, or kind of so the will move, so the according to the external so signals. For example, so the electric or kind of so the change of pH or kind of temperatures. So the maybe so the such kind of so the materials can be applied to so the so-called so the kind of so the kind of real so the kind of so the fake organs so the for the surgical simulation. Of course, so the we are now so the pneumatic and so the or kind of so the hydraulic so the actuators, hydraulic so the actuation so the available, but maybe so the more kind of so the material side so the research I guess needed. So the for the future, so the direction. Thank you.
Thank you. That was a great answer. So actually, before really closing this, I actually wanted to bring up an issue that I think is very pertinent to what we do. So there's always this duality of doctors and on the technical side, maybe roboticists or engineers, and it seems quite hard sometimes to bring research forward because there needs to be a synergy between these two parts of the same coin. And so I know that Dr. Van Velde wanted to say something about this. How do we really, how do we bring these two communities together? How do we build a relationship such that we can make fast progress and really target those areas of research which we need to target for this area to go forward?
Well, to start off, I think we need the right environment, and I suppose the pandemic actually provides the exact perfect scenario. If I were to quote former chief of staff during the Obama administration, Rahm Emanuel, he said that never let a good crisis go to waste. I understand that it's difficult times for lots of people, but we have been forced into this situation where all of us need to adapt technology into our daily lives, whether it's routine or work-related, and particularly in healthcare. I think this is the right time for all clinicians and also people from the technical side, whether it's engineers, computer scientists, people who specialize in AI. I suppose, Luca, you're from AI as well. To really, get on to the task ahead and solve all these problems. I personally feel from the clinician side, because this is what one of the engineers has told me before, that they have a discussion with the clinician, say for example, it's a surgeon, and the surgeon thinks he or she knows what they want. And when the engineer comes back with the solution, it appears that this is not exactly what they wanted in the first place. So there's a lot of miscommunication between the technical side and the clinical side. I find myself, though being a clinician, I'm being sort of like being going forced down this part where I'm between the clinicians, my consultant surgeons, and engineers. And I feel quite comfortable being in that position because I've had like 18 years of clinical experience and also about 5 years in engineering research as applied to medicine and surgery. So I think it starts with clinicians first, being humble and accepting the fact that we need to understand the technology. We need to know the engineering principles, the computer science behind the adoption of robotics and AI as applied to medicine. So that's how I feel that everyone can come together. because based on my experience, well, when I was at Imperial, we were quite lucky in a sense that we had different colleagues from different backgrounds. But surprisingly, there were still two camps. There was eventually the clinical side, which was based at Paddington, and the technical side, which was based in South Kensington, which doesn't work if everyone wants to be in the same page. So if you see how the Russians and the Chinese are going about it, I think that seems to be the right part for me. If you've heard of the Moscow International Medical Center, which is based in Skolkovo, in Southwest Moscow, they've got this whole setup in one precinct. And similarly in Shanghai, the Medical Robotics Institute for Shanghai Jiao Tong University encompasses 3 hospitals, fundamental or basic science research, applied science research, as well as an industrial park. So we've got no choice. We've got to be forced into this situation and work together. And it needs to be continuous feedback. Particularly my criticism is towards the clinicians. We can't be in theater 5 days a week and then meet up with our technical colleagues maybe once a month, once 3 months. That's not going to work. There's going to be continuous collaboration, and I reckon that if we were to actually come up with rapid prototyping and then to test it and then iterate it, there's no other way. And look, we are in the right time at this moment. This pandemic is going to go on for who knows, maybe years. So we could never we couldn't be in a better position to solve these problems that are facing us. Is that answer, Luca?
Yeah, absolutely. No, this is great. I think I agree. We're in a very important time, I think, at the moment, and we're almost setting the stage for how to carry on research in the future, and what are the steps really to make this happen.
Yes.
So unfortunately,
if I just could add on, right, because I'm also assisting one of the laparoscopic surgeons here in Melbourne, and I assist him with holding the laparoscopic camera, but at the same time, I'm working with an engineer where we can develop a shared control mechanism so that the laparoscopic holder can be replaced by an automated device. So which means that I eventually get kicked out from theater, but I'm okay with that, right? So I think clinicians need to be far-sighted in the sense that there are a lot of tasks there, if it's targeted right towards the right discipline or right task, in whether it's in interventional radiology or surgical robotics or even primary care, then we need to take cognizance of the fact that there are some tasks where we will eventually be replaced by a semi-autonomous or maybe even autonomous, who knows?
Mm-hmm. Yeah, this is actually a very interesting discussion. I'd like also to hear Ko's opinion on this, but maybe very briefly. So after Ko's take, we end the panel session.
Sure. No worries.
So, Dr. Ko, do you think the future is added towards robotics being tools to be used by clinicians to do their job better, or perhaps there's also a venue for autonomous systems to, in a sense, replace operations?
I'll probably go hand in hand, I think. To replace, I guess there's still that there is that EQ side, I guess, that we need to weigh in the let's say, for example, we have a very tight lesion, the stenosis all around, then the robotics, for example, says that you need to open up everything, but the heart function is so poor and the patient is already at 90 years old. The risk is high. Of course, on paper you need to open it up, but patient is pre-morbidly bound. They are not really walking, they're not really having a good quality of life. What's the benefit of doing that? So I think it's not just all. I think they go hand in hand. I think yes, definitely there is a role for robotics to assist us in making our decisions. But at the end of the day, I think there's still a lot of role to play. I mean, us as clinicians to decide what is the best choice. Yeah.
Thank you, Dr. Kao. So I think this brings this panel discussion to an end. We're running a little bit over time, but I'd like to thank all the speakers of panel 3, panel 1, and panel 2 as well. We talked about many interesting issues, including the coronavirus and the pandemic repercussions in terms of training and obviously the robotic side of medical diagnosis. And we talked about the issues of haptic sensing and soft robotics and other technologies which really need to be boosted if we want to make an impact in this field, as well obviously simulation for the sake of training and possibly also diagnosis. So without further ado, I'd like to actually give the floor to Angela Faragasso, which is going to make an announcement. Angela?
Hi. So I would like to announce the Best Poster Award. And before, I would like to say that there have been a lot of very nice and interesting work that have been submitted to this workshop. And the awards were selected by a panel of judges. And we use some criteria like content, contribution, and readability of the presentation. And the certificate are awarded by the UK RAS Strategic Task Group of Soft Robotics. And I will present the Best Presentation Award while Professor Maiolino will present the Best Presentation Award in the next section. And I'm pleased to announce that the award goes to Pilar Zankiu, Oliver Thompson, Yon-San Tan, and Bennett Cobley, and with their paper Acoustic Response Analysis of Medical Percussion using a wavelet transform and neural networks. Congratulations to the authors.
Thank you. Wow, thank you so much for this award. We really cannot express how grateful we are to be considered for the best poster. We wanted to thank you, Dr. Angela Faragasso and Professor Perla Maiolino for choosing the project, and also the organizers and the speakers, because the event and the talks on the future of patient care were wonderful. And it's such an honor to listen from experts in the field. And lastly, we want to thank also Dr. Thries and Dr. Nicolas Rojas and everyone else in MorphLab research group, especially Lian He, for your advice, mentorship, and support in the project. So without you, honestly, this wouldn't have been possible. So thank you. We really look forward for the rest of the event.
Okay, so now this brings this first session and panel discussions to a close. I thank all the speakers again, and we'll meet again for the second session in a few hours. Thank you.
Thank you. Thank you.
Thank you, everyone.
Thanks, everyone.
Thanks.
Thank you. All right.
Akina.
So it is on live now. Yeah. Cool. Yeah. Florence, can you double check if it's working now?
Live? Yeah, it is now.
It's
Great.
live. Yeah.
It's live.
Yeah. Cool.
We have around like another 5 minutes.
Great. So Trish. Hi, Professor Halamek. Nice to finally meet you.
Morning, good afternoon, good evening, depending on where everybody's at.
Yeah.
I'm glad to be here. Thanks for the invitation.
It's a pleasure.
If by some chance you see me blink off, it just means my internet went down and I'll connect right back up. Hopefully it's been intermittently with everybody in Silicon Valley working from home and everybody using bandwidth. Every once in a while, I'd say probably once every couple of hours, we lose it for a few minutes and then just have to give it some time. So don't worry, I'll come right back.
Okay.
I think we will manage.
Yeah.
Oh, hi, Trish.
Hi, Trish. I think you're muted, Trish.
Yeah. Can you hear me?
Yeah.
Yes.
Great.
Cool. I think in that case, we can start.
Yeah.
So hello, everyone. Welcome to the evening section of this RoPat2020 workshop for robot-assisted training for primary care. So my name is Liang He from Imperial College London. I'm one of the organizers for this workshop. Me and my co-organizers would like to take this opportunity to bring together roboticists and clinicians from both academia and industry to address the grand question of how can robot help train doctors in medical examination. In the morning sections, Florence and Tilina and Luca.
Hi.
Together with our panelists, have carried out a very interesting discussion on robot sensing, haptics, VR and AR based training and robotic surgeries from both clinical and engineering perspectives. If you missed the previous discussion, don't worry, we will post the recorded version in a few days. I will chair the first panel discussion in this evening section, and my colleague Simon will chair the second panel discussion later on. Hi, Simon. Are you there?
Hello, everyone.
Good. So at first, I would like to start the panel discussion by invite our panelists to give a brief intro about their views. In the first panel sessions, we have Professor Simon Di Lucio from University of Oxford in the clinical side. And we have Professor Robert Howe from Harvard University and Dr. Angela Fagasso from University of Tokyo as roboticist from academia. And we also have Dr. Alan Jiang from Google Health as roboticist in industry. So welcome all to join us in this workshop. Can we start with Professor Simon Di Lucio to tell us a bit more about your thought on the topic?
Thank you very much. I'm Simon Di Lucio. I'm a senior academic GP. I work as a family doctor still 2 days a week, and I run a clinical informatics research group at University of Oxford. My interest in this has come from working with colleagues at Imperial on the RoboPatient and some preceding projects. And I guess what it's completely opened my eyes to has been might be able to measure some of those fundamentally important clinical things we do, that fundamentally important thing of physical examination, and particularly physical examination of the abdomen, where in your training it's often been, or certainly in my training, it was you saw things being done and you started on real people and there was nothing to calibrate, whether you pushed too hard that you might cause someone pain, or you were so gentle that you were unlikely really to feel any important findings. And I think there are ways these technologies could revolutionize the way that we train people, and feedback we might give both to people in learning and later in their careers are actually about how they're doing and whether their approach is the right one.
Cool, thank you. Then can we have Professor Robert Howe, can we hear about what do you feel about the robot-assisted medical training?
Well, thank you. First, I want to start by thanking the organizers. Putting together a workshop like this is always a lot of work. And I think under the current circumstances with videos to upload and Zoom to organize and time zones, I think this has been very well organized. Thank you for your efforts there. So I'm a professor in the School of Engineering at Harvard University, and I've done a bunch of work on medical robotics, especially around the sense of touch or haptics. And we've built those sensors and displays for reproducing tactile sensations on the human hand. And it's been interesting to watch over the last few decades as this technology has advanced. And to everyone's surprise, tactile sensing haptics has not become part of commercial surgical robots. The Da Vinci system, for instance, does not use haptics. And we know how to do that. That's pretty well developed starting in the 1990s. It turns out it's not cost effective, that the costs of adding haptic feedback to a surgical robot are quite high, and the benefit isn't there. And I'm always amused to hear surgeons tell me that the sense of touch is absolutely essential. And then they sit down at a Da Vinci console and do a complicated surgical procedure without the sense of touch. Medical training, things are a little different, of course, but the role of tactile sensing in physical exams is also pretty diverse. My clinician friends tell me that their trainees who have come from developing countries are usually much better at using the sense of touch because they lack the fancy lab tests and medical imaging that we have access to in the developed world. So this raises, I think, the question for us going forward is, what does it make sense to train for in terms of using the sense of touch? I think we need to define particular procedures where it's either very efficient, it's a very quick and easy way to get important information, or it's part of some more complex procedure. So if you endured my keynote video, I talked about training surgeons to do mitral valve repair, which is a complex spatial reasoning task. You have to have a good mental model, and you have to perform dexterous manipulation in order to understand what's wrong with the valve and how to repair it. And that's a task where I think the sense of touch will continue to be important. So one of the challenges I think going forward will be defining just where that haptic information is key and how we can best train it.
Thank you. It's very interesting and important to talk more about the haptics in later discussion. Then Dr. Angela Fargaso, can you share with us a bit about your research?
Hi everybody, I'm Angela Fargaso from the University of Tokyo, and I've been working for many years on sense of touch, so try to retrieve the sense of touch for minimal invasive surgery, so developing effective device by using vision. And I just pick up one of the sentences that one of the clinicians said before: we need more subjective sensation. So I think there is still the need of a more effective device, and I've been trying to understand why many of the research that we perform as engineers are not becoming effective, why there is still the need and what we can do. And I think this type of event in which clinicians and also industry talk together and try to find solution is a way for moving forward. So I hope we can all have some good conclusion from this meeting. Thank you.
Thank you. Last but not least, can we have Dr. Alan Jiang to share a bit more about your thoughts from an industrial perspective?
Yeah, thanks for the invite. I guess a little bit background, I did my PhD in medical robotics at King's College London. So a lot of familiar faces here. And then I worked at Auris Health, where I was working on the Monarch robotic endoscopic platform. I was part of the early team to kind of push that platform out into the market. And then I led a small company called AccuView Incorporated, where we were working on a medical device. It was also an endoscope. And then now I'm most currently at Google Health, where I'm working on a lot of different tools to both enable clinicians to be able to do their job more effectively, as well as consumer-facing products that kind of help users understand, care that is out there for them. So definitely very passionate about medical robotics and the medical device field. I'm most interested in kind of these tools that can really uplift the skill levels of clinicians so that patients can get equal and high quality care. So we know like there's a lot of top doctors, 99% of them, no matter what robotic tool or things, we won't necessarily move the needle on how good they can be. They're already so good with existing tools. But there's a lot of other doctors who can benefit from devices that we develop, and that would really help give everyone an equal opportunity in terms of the level of care that they receive. And so in terms of medical training, I think what's most exciting, either from a software perspective or from hardware robotics, is being able to give a simulated environment to clinicians where they can start to learn more and more about what is the actual patterns they need to recognize, what is the actual ground truth that's important. So like the analogy I kind of would say is like, if you're learning to drive a car, you would want to start in an empty road, maybe. You don't want to start in a busy street with a lot of weather conditions and stuff. You want to start in an empty road where you know the basics, what is important, and you slowly ramp up to more and more different conditions. So similarly for like medical simulation with robotics, it would be very nice, for palpation. This is the thing that you should feel for. This is the actual thing you should learn and recognize. And then you can start to add more and more of the real environment, going into cadavers and going into like live humans. And then, there's a lot of extra noise, so to speak, that they need to kind of filter out. And so being able to use robotics to help those clinicians ramp up into that space will really help them identify what is the target lesion or whatever to identify. So that's what excites me the most.
Cool, thanks. Thanks all for the talks. Now I would like to initiate the discussion with general questions for Professor Simon de Lucien. With the current pandemic, we start seeing more and more people work or have their education remotely, just like what we are doing now on this virtual conference. Do you think it will be a start to shape the way of future medical training? And if so, what do you think robotic technologies would be in this new picture?
Come off mute, sorry. I mean, I'm seeing this happening around me. My practice is involved in teaching and training, and we're having to improvise and use Teams where the student can hear the conversation you're having via a different link with the patient. They can see the medical record, or if it's a video consultation, you can see that. And it's interesting, you learn different things. It's obviously in one sense less of an experience, but the students are really fascinated because they can't usually see the records we're writing and feedback about how it's nicer to see. I can see from the reasoning of the questioning how you're making records within the notes. I think inevitably, two other factors, the fact that people who go into hospital for procedures, when I was, years and years ago in hospital, people were in hospital for 10 days after appendectomies. Now everything's day case and high throughput, and there just aren't the opportunities for students to talk to patients, get to know them over a few days, and perhaps repeatedly examine them as was possible in the past. And so those things, plus I think it is increasingly unacceptable, as I did, to watch one, do one, teach one, as we did in our day, to not have someone at a level of skill when they come to see their first patients. So I would see that the pandemic has just accelerated our need to adopt technology, but there is an underlying need, and I think we can do a lot to give feedback to people through their careers. And another aspect of this I'm really interested in is the point at your career at which you actually learn. I feel over a number of things I did, like examining ears, it was probably only after I became a GP for a couple of years that I really, really was confident that I could see what I could see. And we don't know at what point those skills plateau. And I think, again, some of the feedback we could get from haptic devices and getting people to report on what they can feel and us feeding back could be just extraordinarily useful.
Cool. Thanks for the answer. It seems like with the pandemic, it's actually accumulated our integration with robotic technologies and clinical studies in terms of virtual training. Yeah,
I think so.
So for Professor Hao, as you mentioned in the keynote talk, there's a great potential to have the trainee exposed to diverse disease cases in the virtual simulated environment. We would like to know more about how should we ensure that a robotic approach can be trusted, either in simulation, training, or diagnosis?
Well, certainly validation is the key to all this. And I know that Dr. Ferragasso has, in her technical talk, gone into this in some detail. And it's ironic that this kind of validation, especially in the medical world, can actually be more work than developing the technology itself. We have found that the human variability in training combined with the range of cases you'd like to present is really arduous. The result is that validation is a huge job. And this is just validation in terms of scientific results, not even in terms of regulatory clearance. So it's a big problem, I think, going forward is finding the resources to really demonstrate that these human interface technologies are really effective.
Cool, thank you. So Dr. Alan Jiang, would you also like to comment on this topic in terms of the transparencies and trustworthiness of a robotic approach in general, yeah, from your experience in industry?
Yeah, certainly the same thing as what Dr. Howell was saying. Validation is very important, and it kind of splits into two parts. Working on the IROS platform, it was very important for us to validate both from a safety perspective. So there was a lot of rigorous testing to make sure safety was also split into two halves. There was kind of inherent design, as well as using the test to verify that it is safe. And designing a robot for active safety mechanisms. For example, the robot doesn't it has force sensing and it can detect if it's pushing too hard, so it doesn't puncture the organ or whatnot. So those are like active safety mechanisms that you got to rigorously test to make sure they work reliably. But there is also passive safety systems where inherently it won't harm the patient. So for example, if something goes wrong, you cut power, it doesn't suddenly curl up or move in a certain way that will harm someone. It'll kind of relax or stop, and then you can remove the device from the patient. So testing those safety mechanisms and making sure the design is inherently safe is also very important to make sure that the safety for both the patient and the clinicians working near the system is ensured. And then the second part of making sure we can trust the robot is the accuracy. So a lot of rigorous validation on the accuracy and effectiveness of the robot. So while safety is very important, it also needs to actually work and function to do what it's supposed to do. So in industry, we would always ramp up from in-lab tests using phantom models, moving up to buying organs from a butcher shop and testing it on those, ramping up into live animal testing, and then ramping up into cadavers or even live human trials. So kind of that progression helps us understand both, how it works in the real world and how effective it is. And in those tests, you can make sure you have a lot of additional sensors to measure ground truth, so that when the device is working on its own in the hospital and whatnot, it's actually performing as expected.
Cool. Thanks for the answers. And now I have a question for Dr. Angela Fragasso. As we all mentioned, it's quite important to have sensors and haptic or tactile sensors embedded in the system to ensure a safety interaction. Would you like to tell us your idea about the biggest challenges you faced to address how to develop a robot that can physically interacting with patient and clinicians?
Okay, as said before, first of all, we have to take into account safety measurement. So we have to think that the device we develop have to interact with the patients, and this is not easy. And we need more tests. And as a researcher, we don't have, most of the time, we don't have the possibility to do enough tests as industry can. And we need input from clinicians in a way that the device that we develop are, can for real make difference. And so as in like if we think about software, it's very easy to reproduce and replicate. But when we talk about hardware, and it's much harder. But now I think with the 3D printing technology, we have the possibility to have more reproducible research. And so by sharing our data and like collaborate together, we can maybe have more effective device that can be used in real application. Another problem I think is related to approval. So many of the devices that are developed in research have to go through many approval, and some of them, or most of them, maybe that cannot really reach the market. So I think there is the need to find the link between researcher, so university and industry, and in this case also clinicians play an important role.
Thanks. Since Dr. Fragasso mentioned the input from clinicians is very important, then it's come to another question about how a robotist should collaborate with clinicians. I would like to ask some advice from the panelists. As we know, engineers and clinicians are very different in terms of the expertise. And what do you think would be the best way for these two parties to collaborate on one project? And based on your own experience, do you have any advice for the future collaborations? Professor Hall, can we get some advice from you first?
I'm not sure. I'll try. Let's see. The thing first of all, I should mention I'm mostly with surgeons, which I think is very different from primary care. The whole way of operating, the culture, is very different. I'll say for surgeons, in terms of forming effective collaboration, something I found very effective is to go and see a lot of procedures. Often during a surgical procedure, there's a time when everyone's standing and waiting for the anesthesiologist to do something, for a lab test to come back. And that is quality time with a surgeon. When they're happy to talk to you and answer your questions, and you can get a lot out of that. And these are very busy people. It's hard to schedule meetings with, and so this actually works very well. Something, though, I've learned is it takes a certain kind of surgeon to recognize that this technology development process is long. Surgeons, want to operate. They get rewards for doing surgery, for publishing surgical studies if they're in an academic medical center. And so they want something they can use on patients. And, for new research, that's not going to happen for years. And so you have to find that individual who recognizes that this is a long process and finds it rewarding to be involved with engineers and get involved with their culture and not just proceed immediately to something they can use with their patients and publish in their surgery journals. I've also learned that at the end of the day, you can divide up your projects so that the technology gets published in engineering journals and the initial in vivo studies. So if you do large animal studies, for instance, they can put that in their surgery journals. And so they can get something out of this before it gets to the point where you're ready for human trials.
Cool, that's very interesting. So for Dr. Alan Jiang, since you also had a lot of experience with working with surgeons on surgical robotics, do you share the same view with with Professor Hao?
Yeah, and I really like this question because it is a problem that is not plagued us, but it is a problem that's been ongoing. And the way that in the industry that I've seen us solve the problem is to create this new job role called clinical engineer. So they are pretty much the person that sits between clinicians and the engineering team. They can help translate back and forth. Typically, they were engineers, but they've seen so many procedures and they understand the physiology in that particular field that they start to understand the needs from the clinician and the pain points and kind of the intent for when a clinician says, I want this to be better, or I want a solution for this. They understand how to translate that into kind of engineering requirements or what the engineers need. But similarly, I think one of the good ways to collaborate between the two roles, I kind of, in a way, I kind of see them as very similar. You can imagine like the human body is like just a very, very complicated robot, and a clinician or a doctor is essentially a systems engineer that's trying to debug the system, right? But in terms of translating back and forth, it's very important to iterate together on new designs and new innovations. I think very often the clinician will say, I want a tool that does this, or if you just straight up ask a clinician, what do you want, or what is the problem, they may not give you a straight answer, or the solution that they come up with may not actually be what they want. So it's always a tricky thing where obviously you want to design for what they ask for, but at the same time you have to take it with a little bit of grain of salt. One example, we were developing an endoscope, turning what's typically just a metal rod with two glass lenses, and turning that into a more digital system. So it would have a digital camera at the very tip, a very small sensor. And obviously having a digital sensor enables us to add more software, and it can identify tumors and all these fancy features. But one of the downsides was, when you have just a rod lens and you rotate it, your field of view doesn't change, right? Because it's just the glass that's rotating. But when you put the sensor at the tip of the device and you rotate it, your entire image on the screen rotates. And so we would ask clinicians, is that okay? Do you want it to counter rotate? Do you just want an indicator? And every clinician we asked gave us a different answer. So then we were like, okay, what is the actual thing that they want, right? And we would ask them, how would they want to solve this? How would they want to approach it? And it was a difficult problem. And in the end, we had to just build 3 prototypes, one that rotated with it, one that just kept static and just had an indicator, and another one where we added additional sensors into the device where it counter rotated in software. So it would simulate the idea that it was just like a rod where it wasn't rotating. And initially one clinician was very adamant. It's like, no, it's fine. I don't want it to rotate. I know my own mapping. I know my thing. So just rotate with it and it's fine. And I'll understand. Another clinician is like, no, I'm super confused. I don't know where I am. And it wasn't until we gave these 3 prototypes for them to try that they really understand, okay, if you add a sensor and, come back to the initial experience that I have where I understand, my coordinate system, and you add an indicator to help identify, then they're very comfortable with that. And so it was a good learning experience in terms of like, you just have to iterate back and forth, and, their suggestions may not be ideal, but to understand, like, fail fast, try some prototypes, doesn't work, find a new solution, and you'll arrive to the optimal solution together.
Cool. It seems like they do need a bit of iterations with prototypings to try out first. For the same question, Professor Simon Lucio, do you have any advice for that?
Well, thank you. I'm going to take the bits of advice I noted down from our colleagues as I made some notes I've been learning too. And I was very struck by the sequence about really trying to identify times and places where palpation is really important. That made me think in my medical times too. Do you think it's an acute abdomen, i.e. someone who might have appendicitis who needs to be in hospital, or in the older days, you had to be sure that a baby's head was right in the right place before labor started. And so perhaps finding those things. And then a second point raised by the panel about then knowing when they're reliable, because I like to think I can listen to a chest and know if there's pneumonia, but we've all had times where the lung has collapsed, where you can't actually detect that. So I think knowing when and when it's reliable might drive the areas into which we'd want to keep clinical examination in the curriculum, but also develop the haptic devices and things to be able to train people, particularly for those situations. In terms of getting things going, I mean, I would love to have an extra floor on our practice where Fisher's lab from Imperial is there, and you could interact very readily, and patients who are willing to interact could also interact. And my final thought about this really is perhaps also thinking about the, if you like, the regulators and licensors of people who qualify, because what drives curriculum and curriculums drive learning. And I don't know anything in either the GMC, General Medical Council licensed doctors in the UK, or in the RCGP licenses GPs, that need to have any notion of any of these technologies at all. And is there something we feel that we should be doing in that? And I think for our colleagues, it's very difficult to know what you don't know and to really raise the potential value that this technology might add into knowing the quality of our own practice.
Cool, thanks a lot for the valuable feedbacks. So now I would like to open a bit from the panels. Does anyone have any questions for each other? Or? Any questions? So, okay, in that case, I would like to just back to our aim in terms of primary care training. So I would like to ask, what do you think are the key elements for novices to learn a new technique, such as manual palpations or manipulating surgical tools? Is it more about the environment, or is it about the guide from the mentors, or is the time they spend on practice, or anything else? Probably we can also start with Professor Simon Di Lucio.
I think it has to be, I think these days what we look to do is have a combination of clinical experience and clinical exposure, but also prior to that, perhaps bringing people to a different and a higher level of skills to the days when one just started by going to a lecture and then straight away starting a clinical attachment with real patients. And I think that alluding back to what I was saying earlier about can we find these key areas where it helps decisions and where we think the process is reliable, and really focus on those in our education. Slightly off piece, but I do wonder if in a more general way these technologies were introduced in a less sophisticated way. That would also help acceptance, because one of the other barriers to overcome is that primary care is a very conservative discipline, and probably I think only the legal profession is slower than the general practitioners necessarily in adopting technologies as part of their workflows. So I think getting the people who are setting the example involved in these things is absolutely key if the next generation of trainees is going to come through exposed to them.
Cool, thank you. Then for Professor Howie, so we were wondering, as you mentioned earlier before, is necessary or important to integrate tactile sensors on robotic surgeries to provide feedbacks of the tissue's property, but they always have a different voice in either the user's, the clinician side of it may not necessary to need a haptic feedback, as they can manipulate with just the visual feedback or based on their experience. Or do you think introducing haptic feedback will also affect the way they learn to manipulate the tools, or in general, how would this support the surgical process?
Yeah, well, I think the conclusion from the sort of general surgical procedures that are done with the Da Vinci system is that you work with soft tissues and you provide really good 3D endoscopic visualization, and you can use that visual sense as a replacement for the tactile information that surgeons might be able to gain if they were doing conventional open incision surgery. So there are certainly procedures, though, where the sense of touch is important. And one example is catheter-based procedures and things like epidural anesthesia, needle-based procedures, where you don't get that same level of visualization you can have with a really nice 3D endoscope. And there, the sense of touch is important. So for instance, with epidural needle puncture, you have to feel when you've gone through the right levels of tissue and stop pushing, or you can cause some real problems. And training people to do that using haptics seems a good idea. For some catheter-based procedures, there are in fact training simulators that are used. I understand there's some neurovascular procedures where, in fact, clinicians are required to do simulation-based training with a haptic feedback in order to be certified to perform these procedures. So certainly haptics has a role, and as I said at the beginning, one of the big challenges is figuring out where it makes sense and where it doesn't. If we had listened to surgeons, then the Da Vinci would probably cost twice as much as it does now, and it would have haptic feedback, and it may not work any better than what we have right now. So defining those situations are important. You know, in the long term, if we think about very futuristic surgical systems, you know, where the surgeon has full immersion, you can imagine haptics would have some benefit in making procedures faster and safer. Right now, for instance, you see surgeons doing soft tissue dissection. They go quite slowly because they have to see exactly what they're doing, expose blood vessels carefully and seal them before they cut through them. If you have the sense of touch, you might be able to go a lot faster. You can just feel where the blood vessel is and seal it off before you just do general dissection at a high rate of speed. So there's certainly benefits. It's this cost benefit question that really rears its ugly head. So it isn't anymore just about technical demonstrations about can we generate haptic signals and use them for feedback. It's where does it make sense? Where will it aid in executing a procedure or in training? You know, when is a robot better than a rubber model for training someone to detect lumps? That's actually a pretty hard question. So this is, I think, the big challenge with haptic feedback in medicine right now.
Cool. Thanks for the answers. I think considering the time, we have time for another one questions. So I will open up with more contradictory questions. So how do you envisage robots in the medical field would be like in the future? Would you like the idea of a robot collaborating with doctors, or do you think in the future it will be more like a fully autonomous robot doing the medical procedures? It's good to have everyone's view on this. So can we start with Dr. Angela Fragasso?
Okay, so in my opinion, there will never be like full autonomous system completely able to replace the doctor. So what we are trying to do is not replacing the doctor, but have them to perform easier procedure, even though with the advanced technology, sometimes it's not so easy for them to train. But I think, like as I said before in the previous session, it's nice to have a device that, for instance, can help to have instantaneous presence of the doctor. So some remote device that can connect directly with an expert, a medical practitioner, and have his opinion in real time. But it's not gonna be like replacing the doctor.
Cool, thanks.
In my opinion.
Cool. So Dr. Alan Jiang, do you want to also share some comments?
I think as a sci-fi fan, I think in a very long-term sense, I would be very excited for robots to be fully autonomous. I think to get there, we'll need to have a really good model and sensing capabilities of the human body. I think right now we, like I said, if you imagine the human as like a robot and clinicians is like, systems engineers that can debug the system, they have a model in their head of, what each organ does, how things interact with each other, how, hormone levels and different enzymes work together. But if we had in the far future, we had a really good model and a way to measure that, I can foresee a way where robots can automatically debug the system because we know where all the interactions are. Kind of more short term and that's happening, I think, is there's a lot of devices that are very specialized. A lot of robotics are very specialized in one procedure or one tool or one simulation. And I would like to see that become more generalized. I think that's a goal that we all have. Whereas you have robotic platforms that can end up doing a lot of different things. So then I think workflow has always been a very big pain point for clinicians, and you don't want to wheel in a new device for every single thing where you can wheel in one system and it kind of does a lot.
Cool, thank you. So Professor, how do you think we still have a huge technology gap towards the full autonomous? How do you think it will ever happen?
Well, autonomy in these surgical procedures is extremely challenging to think about. The judgment, if you work with surgeons, you see them do procedures. The manual skills are fantastic, but the judgment, the ability to integrate information from so many different sources, medical imaging, lab tests, interviewing the patients, and they can bring it all to bear in a really expert way. I think we essentially have to solve the AI problem in order to have a prayer of getting true autonomy. Shared autonomy is certainly an interesting idea and makes sense in some procedures. But the surgeons, I think, have good job security for the foreseeable future.
Cool, thank you. So for Professor Simon de Lucien, so even compared to surgical robots, in primary care, probably it's even less collaborating with robotic approaches. What do you think about the futures for collaborating in primary care diagnosis?
I do wonder if there are particular groups of patients or chronic disease groups where the potential for greater systematic data collection, and obviously one's got to remember that in primary care, the bulk of our decision making is by watching the patient and questioning them. Yet, to be honest, the decision about the level of illness is often made incredibly early on. I always go, for example, the waiting room to bring in my patient in person, because just watching the way they get up and move and things, you almost know before they set that, you get some sense of where they are and how they are. So I don't know, I suppose I see a more sort of augmented decision-making process and things that might help us rule in and rule out, because often when we get to the examination point, it is to test a hypothesis that you have as to whether this is a particular condition or not. But I think around more systematic data collection, presenting and focusing, there could be an awful lot that be done. But I think the broad task done autonomously
Thank you for the answers. Great, we finished exactly at the time, and thank you all for the participant in this panel discussion. I hope you have a nice day, and I will pass the talk to my colleague Simon for the next session. Simon?
Yeah, thank you, Liang. So welcome to the last panel discussion. I'm Simon. I'm a postdoctoral researcher in the Bio-Inspired Robotics Lab at Cambridge. And I would like to invite the speakers for this panel session. This is Professor Shinichi Hirai from Ritsumeikan University in Japan, Professor Perla Maiolino from the University of Oxford, Professor Lou Halamek from Stanford University, and Professor Rachel Jack from the University of Glasgow. And we have an extra guest, Professor Philip Shins, also together with Professor Rachel Jack. So I would like everybody to give a brief introduction about their work, and maybe let's start with Professor Lou Halamek.
Morning, good evening, everybody. I am a practicing neonatologist. I've been at Stanford working in the level 4 NICU for the last 30 years. And I've been involved with healthcare simulation and debriefing for about 25 years now, primarily using physical patient simulators. I have some experience with virtual reality-based simulators, but the healthcare community has embraced physical simulators, at least for the time being. I also recently completed a 6-month faculty fellowship in Stanford's biodesign program, some sensitized to all of the issues, many of which were brought up by our previous colleagues, around the cost-benefit ratio and the return on investment issues around some new technologies. So that's what I've been doing for the last 3 decades.
All right, thank you for the introduction. Let's continue with Professor Perla Maiolino.
Hello, everyone. I'm Perla Maiolino from the University of Oxford. My background is in the development of large area tactile sensor for robots, like artificial skin. And I had the pleasure to collaborate and work with Professor Trishanta Nanayakar and Professor Fumiya Ida in the Motion project, which was related to the development of palpation robots, but also to understand the complex dynamics of sensory motor coordination during palpation diagnosis. And I'm still collaborating with them now for the development of physical simulator of patient. Thank you.
Thank you. Let's continue with an introduction of Professor Shinichi Hirai.
Yep. Okay, so my name is Shinichi Hirai, so from Ritsumeikan University. So I am now in mechanical engineering. So working on the robotics and the haptics. So now we are building the physical simulator for education of nurses. So because nurses use many haptics in the activities. So now for their training, we are now building the physical simulators with haptic sensing. Okay, thanks.
Thank you. Now I'll pass the mic to Professor Rachel Jack.
So hi everybody, I'm Rachel Jack. Thanks very much for inviting me to this discussion. I'm a professor of computational social cognition at the University of Glasgow, and my research focuses on building generative models of dynamic 3D social signals such as facial expressions that you can see here behind me. And we do this using methods from psychological science, such as psychophysics to reverse engineer these signals directly from human social perception, such as perceptions of happiness, trustworthiness, attractiveness, and so on. One of the strengths of using this psychology-based, data-driven approach is that we can capture and understand variations in social signals across individuals, but also across groups such as different cultures. And this enables us then to represent these social signals in all of their complexities and nuances. So Alan was talking about really great models. So that's what we're doing, is that we're improving models of social signals from using directly social perception of humans. So this has a direct application in social robotics, because we can then equip digital agents with these generative, culturally sensitive, or even individually bespoke models to enhance their social signaling capabilities.
Thank you. And finally, Professor Philip Shins.
Yes, hello. So I'm Philip Shins. I'm professor of visual cognition and visual neuroimaging. I've worked with Rachel on developing those digital avatars and those models of social perception. She's eloquently described what these were about. Just to add a few dimensions to this, we can, of course, now reverse engineer, for example, the 3D face morphology or the 2D face complexion to add to the facial movements she discussed in order to, say, make a face more warm, more trustworthy, which in interactions with digital avatars or social robots will be very important to facilitate the interaction. We can also transfer these models as drivers in collaborations that we have on the future of artificial skin, so that we will be able at some point in the future to have artificial faces that express either facial expressions or are designed to change dynamically to be more warmth in the social interaction and also sense. And in addition to this, I look at how the brain analyzes these social dimensions.
Right, thanks for everybody's introduction. So I would like this to be a discussion. So if some speaker has a question for anybody else, then just feel free to ask the question directly. My first question would go to Professor Halamek. You talked about in your video presentation about gathering objective data of performance and kind of performance metric. We heard that also subjective data is important. And on top of that, Professor Howe was mentioning before that sometimes it's not even clear what type of data actually is needed when he mentioned the Da Vinci robot that does not have haptics. And clinicians and surgeons can still perform. So what are your thoughts on this here? How should we gather this objective data? What do you know what is important?
Well, I work with patients as small as 450 grams in my newborn intensive care unit. And so when I think about objective data, you know, these are patients who can fit in my hand. And so if I am trying to assess pulses, for example, because physical examination, detection of pulses, that's one of the first cuts for determining whether a patient may have a cardiac output problem or congenital heart disease, for example. And those are very important things to pick up. So before you would order an echocardiogram to look at the patient's heart, you'd want to do a good physical exam. And pulses are graded, there are different ways to grade them, but they're often graded from 0 meaning absent to 3+ meaning bounding. And then 1+ and 2+ are in between somewhere. And so my 3+ may be your 1+. But when we have to communicate as fellow healthcare professionals, we need some consistency. So when I think about objectivity and where robotics or types of similar devices could, you know, where could they provide objective measurement of those types of things, which would be standardized across all patients and not dependent on the size of my hand, the thickness of my fingers, whether I've got good perfusion that day or not. Those are the kinds of things I think would be really helpful for us to bring into our clinical environments and provide that objectivity, at least as a first screen. And then the physician or the allied healthcare professional could go in and follow up on that information that's relayed to them by the device that's in use.
Okay. So then a follow-up question to Perla. Actually creating sensors to gather all of this information is a hugely difficult task, and now we hear that we have patients that are human-sized, but down then to the patients that Halamek just was mentioning. What's the current take on the sensor development at the moment? Like where is it? Where should it go in the future? Your thoughts on that?
Yeah, I think that, I mean, tactile sensing is around since 90s, as Professor Howie before said. So actually, we develop a lot of different type of tactile sensor and haptic device until now. But I think that one of the first challenges, in my opinion, is the complexity of this system. So to try to replicate the complex interaction between our skin, our sensing abilities, while doing some palpation diagnosis is very hard. And also, I think that we need to find a trade-off between trying to actually develop system in which the complexity scale up, but in the same time to look at what is really needed. So I think that we need to look at these aspects, so and try to develop sensors that provide what is needed, but without actually add on to the complexity of the system. When I had to design a artificial skin, I mean, it was very easy to scale up in the complexity because you have many sensors to read. So this means also from the control perspective, these add additional burden for the process of the data and close the control loop of the system. And this, of course, if we are thinking to like a sensor that needs to detect a contact and provide feedback to a surgeon, this can be an issue. Also, the problem that, for example, Professor Howie before said, like complexity. So if we develop complex systems, this also means that these are not cost effective. We have problem in integration with the real system we have at hand and we use currently, and we have also a problem in like verification, for example, because as much as the system is complex, it's more difficult to verify if it's if it is working properly for the situation we want. So I think that we have a lot of examples of tactile sensors around, or like haptic devices, but we need really to focus on try to get the most of these devices and to design them in order to get the most from them and provide the right feedback to the surgeon or to the practitioner. But in the same time, trying to create a system that are not too much complex, because in this way we can effectively integrate in like the available surgical robots, or actually we can add additional sensing modalities, for example, for device that can be used in training.
Thank you for the answer. So on the same line for Professor Shinichi Hirai, you showed in the morning a dental care device, and you showed the first iteration of it and then the second iteration of it. So how did you decide on the second iteration? Like, we are talking now about sensor and cost effectiveness. So is the second iteration, let's say, cheaper, or did you have inputs from clinicians on what to do, what to improve actually from your first prototype?
Okay, so the first prototype was we put the two sensors for each teeth. So we have many methods sensors, so in the real simulator. But so the problem is, first was the complexity. The second one, basically the professors in the nursing department want to apply many many tooth models. So the older ones, so the younger ones, so children, different size, different so the arrangement of the teeth. So in this type, so we have to develop, we have to attach many sensors for each model, for all models. So we have much complexity. We had much complexity. So that's why we decided to to separate the teeth model and also the measurement system. So second prototype, we just use only single the general force sensor. We just attach the tooth model on top on the sensor, and also we just develop the kind of the sensor algorithm to detect the force and also the force application point. So this is the key to reduce the complexity. So the sensor algorithm is a key. So it suggests us of course we try to we should try to develop sensors, but also at the same time we have to develop sensing algorithms. Okay, so using even though using cheaper sensors, we may obtain rich information. Maybe recently we have many machine learning techniques so on. Maybe this is another approach. Yes. Thank you.
Thank you. Yeah, for the answer. Yeah, again on the same line now for both Professor Jack and Professor Shins. So I'm guessing rendering facial expressions in virtual reality or in augmented reality might be more cost effective to do than actually building robot platform, but then you might not have the same type of interaction with these devices. Do you see, or let's hear maybe a bit advantages and disadvantages from doing let's say a virtual patient versus actually a physical patient, if you have any comments to share on the advantages or disadvantages of those approaches?
Well, there's some evidence to suggest that with a physical agent, if you like, there's more of a qualitative interaction with the agent. With a physical agent, obviously, you have some limitations as to which kind of materials that you can use and how those materials can then be used to express different social signals. I think that with VR now, given that when people have this experience in VR of really having a sense of depth and having more of a qualitative experience with the virtual agent, that opens up a lot of new opportunities for the range and flexibility of social signals that a digital agent could generate. And that may overcome then some of the limitations of a physical agent. The only thing, of course, in VR that's missing at the moment, but I guess these are things that components are being worked on, are aspects such as touch, because touch is very important in social interaction. Obviously, it's very important in a lot of contexts, such as in this context of medicine as well. And so, although in VR you have a sense of being with that person and you have a lot of visual cues for depth and so on, there's a lot of social signaling can go on. It still does lack some of the relevant components of a social interaction. I would be quite interested to hear more about some of the technological developments in touch, for example, in VR. Philip, do you want to add anything?
Yes, just to add to what Rachel says, of course, the VR platform offers a great technology to develop the sort of avatars with the right sort of social dimensions that would be conducive to strong interactions with patients, for example. And while this is done, it provides ample time, well, ample, how ample we will see, to develop artificial skin, to develop skin that can be stretched to have certain expressions of the face of an actual physical device, and also have a skin that can feel, so that touch can be implemented at the same time. And hopefully, by the time all of these technologies converge, drivers will be ready from the VR technology to be adapted to a physical device.
Okay, thank you for the insight. So it seems maybe really this combination of augmented reality may be a nice middle ground to have the advantages of the virtual reality, but then sensations from the actual reality. So question maybe for Perla, the tissues and the materials that practitioners interact with are all soft. Now you in the technology side are dealing with soft systems. Can you give maybe a bit insight in sensory development for soft materials? How is this going? How this is a difficult subject to tackle, but where do you see this in the next couple of years going?
Okay, it's a big question. Of course, I think that, yeah, I first of all, my first experience with sense of touch was actually developing a conformable system. So not stretchable, but conformable to, let me say, 3D surfaces. And that were providing up to 1,000 of contact points when integrated on a robot. And of course, that kind of technology was providing some challenges. First of all, in the type of contact events that you want to detect. Because, for example, to replicate exactly our sensor touch is very hard because we have several mechanoreceptors. So to try to detect all the complex dynamic of touch with a single sensor is quite hard. So that is the first aspect. So try to replicate sensor touch require like multimodality, of course, and so different type of modalities. In terms of like soft sensing, there are like additional challenges that are due to the fact that we want to provide like sensor that can be also stretchable. And of course, until now that we had like several groups that worked on stretchable electronics. Of course, for example, as Angela Faragasso mentioned before, 3D printing, additive manufacturing is also providing a lot of support in this respect. So the technology of additive manufacturing is helping to achieve more stretchable circuit to get like a stretchable soft sensors. But of course, we are still limited. So if depending on the scale of your sensors or how many contact points you want to get, these add on additional complexity about readout electronics, of course, how you connect these single elements to the readout electronics. So of course, and also the fact that when you have, your measurement system should be repeatable, should be reliable. But when you are like considering a soft sensing system, these are embedded in like usually non-linear hyperelastic material. And of course, these material are affected by hysteresis, by nonlinearity, by aging, for example. So your sensing device is also affected by this problem. So you would need to recalibrate after some times because like the medium in which they are embedded like change this their property. So of course these adds additional challenges because again, as we said before, we are trying to, especially in application, medical application, we want to have to develop systems that can be trusted. And of course, a measurement system, something that should provide you feedback, should provide you the same feedback when the same type of contact input happen. So of course, if your measurement system is affected by problems like aging or by nonlinearity or by hysteresis, this also add on additional challenges to this.
Thank you for the answer. So there was a question that I would like to ask Professor Halamek from the morning, actually, for artificial reality in medical schools. And I'm going to read the question for you. Is how far in the future would you feasibly project AR, artificial reality, training to become widely applied and accepted in med schools, training hospitals around the globe?
And since I missed the morning session, could you define artificial reality?
Sorry, it's augmented reality. I was
oh, augmented reality. Okay.
Yeah, sorry. Augmented reality, yes.
Okay. Well, certainly the need is there right now. If we look at what we can do with physical patient simulators, for example, cutting and sewing those ends up really having to increase your budget because you have to buy new ones all the time. And so having an augmented reality type device is something that we desperately need right now. I think that I would hope that the time horizon on that is somewhere within the next decade. A lot of that depends on funding. And unfortunately, what I've seen is that if we think about a lot of these kinds of devices, boy, if you've got an entertainment application, it's pretty easy to get funding, relatively speaking, to say you're going to focus this on medical and nursing schools. And so I think there's an issue of, will industry actually develop the products that medical students and nursing students and other allied healthcare professional students need? And then there's the process of working through the regulatory bodies, like in the United States, the Accreditation Council for Graduate Medical Education. You want to show, as people were mentioning earlier, the validity of that training tool. It can actually train people to do the things that we think it should be able to do. And so there are a couple of big hurdles there in terms of interesting industry from the financial standpoint, making the cost benefit or the return on investment argument, and then the regulatory argument. So I think that those are the rate limiting steps right now. The need is there without a doubt, but those are two big hurdles that we'll have to overcome.
Yeah, thank you. And then for follow-up on this, for Professor Jack and Shins, do you share the view on the 10-year timeline for using augmented reality widespread as an application?
So I would agree that it sort of depends in part on funding, obviously. I think that there's quite a ways to go in terms of the signaling capabilities of digital agents, and we're doing a lot of the work there to improve the signaling capabilities. So currently, a lot of digital agents or social robots have a very limited social signaling capability that's primarily based on so-called universal facial expressions, but they're not universally recognized. It's a big misunderstanding, basically. So I think to be able to get the technology, the digital agents in terms of their capabilities up to speed for a global market will take a lot of work, but I can see that possibly happening within a 10-year period. We would still need funding to be able to do that research so that these agents can generate nuanced social messages. Fear and disgust only get you so far, and they won't be recognized oftentimes outside of Western culture. And this also depends on the target audience. So digital agents that are, for example, used to train doctors to deliver bad news, they have to exhibit a range of different emotions, anger, shock, etc., to be able to capture the realistic variations of human responses in different cultures as well, and to represent this on digital agents of different ages, ethnicities, shapes and sizes, all of this. So what we're looking forward to really is to be able to be guided by the demands of the market, so that research can be focused on developing the necessary social signals for for a given role. And as was just mentioned, funding can help expedite that process.
Thank you. Professor Shins, anything to add on that? Or
just one little word, which is the general warning that artificial intelligence has had a great history of making very strange time predictions, which typically haven't been fulfilled. But as Rachel says, I think the beauty that exists now is that there's a convergence between psychology and modeling, which is such that we can translate psychological theories into actual models of social signals. And so it is indeed now a question of having enough funding to be able to push this agenda through over the next 5 to 10 years to try to have these drivers that will be so important to guide nuanced social interactions. So 10 years, I don't know, but we are certainly going in the right direction.
okay, thank you all for your insights. I will open briefly, we are on time, but I would like to briefly open the discussion if anybody has a question for any of the speakers right now.
You know, Simon, if I could just say one thing, sort of, given that we have such an august panel of professionals, you know, a couple of key points, I think, when we talk about engineers and physicians and moving this field forward, I think collaboration is the key. We have to learn how to speak each other's language. That's going to help a lot. We shouldn't meet once and then not meet again for 6 to 12 months. Alan mentioned earlier to be able to iterate together and fail fast. I think those are really important things. We also have to have some agreement on the balance between sort of the features, the necessary features that we need and the nice to have features, but the necessary features and the cost and time of development that it takes. When we talk about implementing these tools within medical schools or actually out there in clinical practice and really know when it's good enough as opposed to trying to reach for perfection and over-engineering. And the second point, summary point is don't start with the technology and search for applications, but actually do a needs analysis first, because healthcare, our needs sometimes shift and they're vary, and what they may be today, they may not be tomorrow. And so the needs analysis can then drive the technology development rather than the other way around.
I think you just provided an excellent summary of practically the whole day from our discussions. Thank you, Professor Lamek, for these remarks. I would like now, unless there's any other question, I would then move on to the Best Presentation Award, and this is presented by Perla. So I would like to give the mic to Perla again for this point.
Okay, it's a great honor for me to announce the Best Poster, Best Presentation Awards during this session. I want to mention that there have been selected based on like some criteria that were related to the content, the contribution, and the presentation, and that the best posters today were selected by a panel of judges. So the certificates also are awarded by the UK IROS Strategic Task Group of Soft Robotics. And the best presentation awards goes to Yongswan Tan, Pilar Zhang Qiu, Oliver Thompson, and Bennett Cobley for the paper entitled Design and Implementation of a Robotic Device for Medical Percussion. And congratulations to the winners, and also to everyone to attend today's workshop.
Thank you very much. Yeah, the team here, Pilar, Ben, and Oli, we work very hard on this project, and we're currently still developing and performing more experiments, and we're aiming to publish or work further as a journal paper. And here, yeah, we'd like to thank you again, the judges, for choosing our project. Also, thank Thresh for supervising us, and Liang for helping us with all the prototyping and experiment setup stuff. Hopefully we'll be able to get more insightful results from our new experiments, and can't wait to share our new findings with you guys. Thank you.
Thank you so much.
Thank you, Perla, for the presentation. So this is the end of the day today. And I would like to thank all the speakers for today, also from my panel and from all the panels that we had today. It was very interesting discussions. Let's try to take the chance and go into collaborations, like Professor Halamek said, not just every 6 months, but every 6 hours maybe, and take the opportunity to really develop collaborations and bring this dream of ours forward. I give the mic now to Florence for a few closing remarks. Thank you.
Thank you so much, Simon, and thank you everyone for joining us in the discussions today. So I think we have had a lot of interesting ideas and also discussions going since the morning session until now. And I think we have a lot of key valuable takeaways from the discussions on whether we need haptics, whether we just depend on like visual cues or auditory cues, and also the practices that we as technical engineers apply onto clinical practice. So I truly agree with Professor Lo Halamek that collaboration is the key here. So we get to work together to bring the technology, to make the dream come true. Yeah. So basically, to have like the industry, all of us from academia and also clinical side to come together, talk about requirements, talk about the considerations that we could provide to help the clinical side to actually come out more effectively. Yeah. So with that note, thank you again, everyone. And I hope you enjoy the discussions as much as we do. I thank all the panelists, all the organizers of the workshop, and also, most importantly, panel speakers. Yeah, so thank you for making this workshop a success.
Thank you.
Welcome. Thank you.
Thank you.
Thank you.
Thank you, everyone.
Thank you.
Thank you, everybody.
Bye.
Yeah, keep in touch. Alan,
Collaborations.